may be found in 30% of patients, but unlike rheumatoid arthritis and Aismoc, patient tends to get more of large joint arthritis like hips, knees, shoulders. Sternoclavicular joints are also commonly involved in Aismoc. Enthesitis is also very common, 30 to 35%. Most commonly in the Achilles tendon as shown in the picture. Apart from that, plantar fasciitis, the patella, the tibialis tuberosity, tenderness, costochondral junction, the patient complains of pain in the chest, increases on respiration, the patient goes to a cardiologist, does a coronary angiogram, it's normal. So these are enthesitic pain in Aismoc. Then the sternoclavicular joints, the superior iliac crest. So these can be enthesitic pain in Aismoc. Then dactylitis may be present in 6% as shown in the picture, entire swelling of a digit, a particular one digit in the hands or feet. And extra-articular manifestation, acute anterior uveitis. So about a patient of Aismoc can have a 30% lifetime risk of developing anterior uveitis, and it's mostly unilateral. So it's like bilateral pain and redness is unlikely to be caused by uveitis. Inflammatory bowel disease, asymptomatically it may be present in 50%, but overt IBD is present in about 4 to 6% of Aismoc patients. Psoriasis may also be present in 10%. Other extra-articular manifestations, less common, fibromyalgia, osteopenia, osteoporosis. Because of continuous inflammation in the spine, patient gets to tend to have a lot of osteoporosis and easy fracture risks. Aortic regurgitation, conduction disturbances. Then restrictive pulmonary diseases causing difficulty in breathing. Apical pulmonary fibrosis, which is mostly asymptomatic. So what are the complications we usually get? First is vertebral fracture, not at all uncommon. We definitely get a lot of patients, mostly the lower cervical or the upper dorsal spine is involved, because anyhow the spine is fixed, osteoporotic, and with some easy twist or fall, patients get to have vertebral fracture. Second is neurological manifestations. Many a times we see Aismoc patients getting admitted with paraparesis, monoparesis. So there are multiple causes because of which there may be cord, spinal nerve compression, maybe due to a fracture, maybe ligamentum flavum hypertrophy, OPLL, atlantoaxial subluxation, etc. Less common, renal diseases like IgA nephropathy and renal amyloidosis we also get to see. So men and female. So as I was discussing, the ratios of male and is to female ratios in Aismoc are gradually decreasing. Women are also having equal amounts of Aismoc. But there are some clinical differences between women and men Aismoc. So usually in women they tend to have lesser inflammatory back pain, less of symptoms, less severe symptoms, less structural damage, slower radiographic progression. We don't see much of a hyperkyphosis of the spine as we get to see in men. Rather, peripheral manifestations are more. Because of these, women get to have a longer diagnostic delays and may present a little later in the disease course. So how do we investigate these patients? So coming to blood parameters, we get to do an HLA-B27 positive or not. In 90% of Aismoc, usually we get to see an HLA-B27 positivity. But one thing I would like to say, always HLA-B27 positivity is not equal to Aismoc. So there may be HLA-B27 positivity, but the patient may not have developed Aismoc. Even family members of Aismoc, though at an increased rate of having the disease, may not have developed it, then may have HLA-B27 positivity. So we have to address other factors also before diagnosing a patient as AAS. Coming to the imaging parameters, first is an X-ray of the sacroiliac joint, a pelvic X-rays. First and the foremost thing we need to see before suspecting a patient to have AAS. Also a vertebral X-ray in advanced disease which can reveal bamboo spinal syndesmophytes. MRI sacroiliac joint is very sensitive to pick up early disease. Apart from them, for late or advanced disease, CT scan can also be done of the pelvis. And for detecting enthesitis like with the Achilles tendon, and ultrasonography may also be an easy technique. So these are the X-ray pictures. So the first is grade 1, as you can see in the picture. So this is a suspicious change, it's very blurring. This is a sacroiliac joint, very mild blurring. Grade 2 is some small erosions or sclerosis. Grade 3 is sclerosis, widening, narrowing, or partial ankylosing. And grade 4 is total ankylosis of the sacroiliac joint. It cannot be visualized only. So we can only say the patient is having sacroiliitis radiographically or in X-ray if the patient has grade 2 sacroiliitis bilaterally or grade 3 sacroiliitis unilaterally. If anything less than that, suppose unilateral is grade 2 or bilateral grade 1, it is not sacroiliitis as per radiographically or X-ray. So as I was saying, radiographic sacroiliitis is more than grade 2 bilateral or grade 3 unilateral, and these are the patients we say Aismoc. There is a category of patients who is less than that. As I said, grade 1 or grade 2 unilateral sacroiliitis. This is a different entity, non-radiographic axial SPA or NR axial SPA. So here radiographically we don't get to see much sacroiliitis. The disease manifestations are less severe, milder form. Women tend to have more of an NRSPA. Approximately 10 to 40% of patients with NRXPA or non-radiographic XPA may develop Aismoc within the next 2 to 10 years, but with good treatment may not develop also. So MRI sacroiliac joint is the gold standard of diagnosis. So the best thing that we see is the bone marrow edema or the osteitis for active or acute inflammatory lesion as shown in the picture. And the best sequence is that STIR or post-GAD T1. So here we see whether of course the radiology sees the osteitis, capsulitis, synovitis and enthesitis. Chronic lesions not very well visualized in MRI, a CT is better, but sclerosis, fat deposition, ankylosings are also visualized in MRI. So to properly diagnose a patient with axial spondyloarthropathy, the back pain has to last more than 3 months and the age at onset has to be less than 45 years. With or without peripheral manifestation, the patient has to have an inflammatory back pain. With these background, if there is a sacroiliitis on imaging, be it X-ray or MRI, plus at least one or the other SPA feature, or HLA-B27 positive plus 2 or more SPA features, then only we can say the patient has spondyloarthropathy. The SPA features as shown in the box below: inflammatory back pain, arthritis, enthesitis, uveitis, dactylitis, psoriasis, Crohn's, good response to NSAIDs. So this is also a very important thing when we take a history of Aismoc. Family history, HLA-B27 positive and elevated CRP. So how do we monitor once we diagnose the patient? So how do we monitor? So BASDAI and ASDAS, the two sets, and it's present in our mobiles, our calculators are there. Very easy questions. BASDAI is mostly clinical. If a score of more than 4 is there, it is an active disease. ASDAS is this. We ask the overall, the neck pain, the spinal pain last 1 week. How much is this morning stiffness? How active has been your overall disease? Is there any pain in the peripheral joints? If so, how much? And the CRP level is also documented. If the score is more than 2.1, it is an active disease and rheumatologist intervention is needed. So how do we treat a patient? Phase 1, when the patient first comes to us with the diagnosis and we confirm it. So the first of all, we start off with NSAIDs. So NSAIDs is the first line treatment in any patient of Aismoc. At least a trial of 1, maximum 2 months we can give, of 1 or 2 NSAIDs. Along with that, we need to ask the patient to do good amount of exercises, stop smoking, swimming, so physiotherapies. So we have to assess the response after about 2 to 4 weeks. At least 2 NSAID course has to be given if the patient is not responding to 1. So if the patient is still having an elevated CRP, active MRI sacroiliitis, failure of at least 2 NSAIDs over 1 month, or a trial of sulfasalazine or local intraarticular steroid injections has been given, and as I was saying, high disease activity as per ASDAS is more than 2.1. In that situation, we move on to stage or phase 2. So in this we do is, for axial pain, there are 3 options. One is TNF inhibitors, IL-17 or secukinumab inhibitor, and JAK inhibitor. So these are the 3 molecules we use in after about 1 month of failed NSAID trial. So if the patient is having coexisting recurrent uveitis or active inflammatory bowel disease, then we choose TNF inhibitors preferred than the other two. But if the patient is having significant psoriasis, in those situations IL-17 is preferred than the other two. So how to choose, we'll just discuss in a short way. After a trial of these biologic or tofacitinib group of medicines, if still is no response, then we can switch to another biologic or switch to tofacitinib and try. So what are the options? We'll discuss in short. TNF inhibitors, these are the 5 molecules we have, not 4 molecules, the upper 4, etanercept, infliximab, adalimumab and golimumab, which is there in Indian market right now. So there are some problems with TNF, and though it's a though the guidelines, as I said, any of the 3 can be used at any point of time, even when the patient first comes. But still, we have to know the problems of each. Then only we'll be able to choose which one to use first. So first is TNF inhibitors. It's difficult to give on a long-term basis. After 1 year, 2 years, 3 years, there's a tendency to develop antibodies and the tendency for the efficacy to come down. Then we have to switch not only to another TNF inhibitor, but it's preferred to switch the group of medicines. So the options come down. Second, as we all know, there is always a risk of reactivation of latent tuberculosis with TNF inhibitor. Thirdly, though very debatable, there is some increased risk of cancers like lymphomas and non-melanoma skin cancers, or at least in a patient who has a past history of cancer, better to avoid. If the patient has any coexisting heart failure or any demyelinating diseases like MS, multiple sclerosis, prefer to avoid TNF inhibitor. Also, if the patient has other autoimmune conditions like lupus, so it has a tendency to spark off new autoimmune symptoms or new psoriasis lesions. This is known as a paradoxical reaction of TNF inhibitors. If we give a psoriatic patient, there may be a paradoxical aggravation of psoriasis. So these patients, definitely IL-17 inhibitors are preferred. So coming to the latent tuberculosis reactivation. So there's a 3-fold risk of TB risk after an exposure to TNF inhibitor. What we do in every patient, when we know that we're going to start with TNF inhibitor, we should do a Mantoux test or a quantiferon test. Quantiferon test is better because it doesn't cross interaction with the non-tubercular mycobacteria is not there. But coming to cost, patient can go ahead with a Mantoux also. If the Mantoux is negative, straight away we can go ahead with TNF inhibitor. If the Mantoux is positive, then we have to challenge the patient. We have to give some other regimen. It can be either 3 months of INH rifampicin, can be 4 months of only rifampicin, or about 6 months of isoniazid alone. After starting these ATDs in half doses, then at least 3 weeks gap, then we start the TNF inhibitor. But it has been found, even after proper LTBI treatment, about 2.7% patients may still have tuberculosis. What happens is mostly in Indian population, we are very frequently exposed to TB germs. But there is an efficient granuloma formation in our bodies, in our lymph nodes, that contain the MTB germs. But whenever these TNF inhibitors are coming, so that the granulomas become altered with fewer epithelioid cells, with defects in the cytokines, altered B cell response, the granuloma starts to loosen up and the TB germs, they disseminate to the local lymph nodes and the bone marrow. So, and the other thing is that mostly after TNF inhibitors, we almost, at least whatever TBs I have seen, most are extrapulmonary tuberculosis. Again, a bit difficulty in diagnosis. So the next group, as I was saying, is the JAK inhibitors. Nowadays we have 2, initially we only had tofacitinib, but now we also have upadacitinib in our market. Very frequently, non-rheumatologists also I've seen prescribing any joint pain before even going ahead with rheumatoid arthritis tests, just tofacitinib 5 mg BD or 11 mg OD. But we have to consider that we have to look ahead, we have to see that at all if it is needed or not. What are the side effects? What things we have to ask the patient? What things we have to exclude? Then only we should challenge the drug. So there is definitely an FDA black box warning for JAK inhibitors for cardiovascular events, cancers, blood clots and death, specifically in patients more than 50 years. So we have to be very careful when we are challenging it more than 50 years. In more than 65 years, only JAK inhibitors should be used only and only if nothing else can be used. And not only this, apart from that, JAK inhibitors have also been found to have an increased risk of herpes zoster. So if we can wait for at least some 2-3 months before starting JAK inhibitors, prefer that we give Shingrix vaccine and then proceed. But there's also some good things that JAK inhibitors have also been found to be effective in patients who are failing biologics. Like TNF inhibitor, IL-17 inhibitors, they failed. In those patients, if given JAK inhibitors have been found to respond to it. And it's also effective for patients with non-radiographic spondyloarthropathy, as I was discussing earlier. So coming to the cardiovascular risk of tofacitinib, it has been found it increases both HDL and LDL. But thankfully, there's a little change in the LDL-HDL ratio. This ratio is moreover a marker of cardiovascular risk. Some data extrapolated from rheumatoid arthritis, the STAR-R8 trial, which is done in more than 1 lakh rheumatoid arthritis patients, it was found, in this tofacitinib was compared with TNF inhibitor, and it was found that tofacitinib was not associated with risk of composite cardiovascular outcome in general. But if a patient has a history of cardiovascular disease, in those patients, tofacitinib was associated with an increased risk of cardiovascular outcomes as compared to TNF inhibitors. Coming to the last of the three drugs which I was saying, IL-17 inhibitors. Out of these three, only one is in the market, secukinumab. So the good thing is that it's preferred for patients with significant psoriasis, doesn't have any risk of reactivation of latent tuberculosis, so safe in patients who have a past history of tuberculosis. But there is one thing, if the patient has any inflammatory bowel disease, it may worsen it, better to avoid. Also, it has an increased risk of infections, but mostly upper respiratory tract or candidiasis. So, preferably safer of the three, but cost-wise also slightly more than the three. So, just before ending my talk, I would like to discuss two cases. So, this is one case, a 44-year-old man who is a known patient of ankylosing spondylitis. He had an aggravated low back pain about a month back, and he's taking non-steroidal, he was taking etoshine with some partial response but were not responding, and the CRP was found to be lot high, and this is the MRI picture. And a CT guided biopsy was done, and it revealed some necrotic fibrocartilaginous tissue along with some scanty inflammatory infiltrate with plasma cells, lymphocytes and macrophages. But there was no epithelioid granulomas. Manto was borderline, about 15 millimeter in duration. So anyone can say from the audience, what is this picture which is on the right side? So this is an Anderson's lesion found in ankylosing spondylitis. It very much mimics tuberculosis or Copot spine. But we have to be very careful, and we have to talk with the radiologist as versus Pott spine, in which particularly the disc is involved, the disc is destroyed here, and also there is maybe some collection locally. In Anderson's disease, the disc is not involved much, rather is a paradiscal part of the vertebra which are inflamed. So the problem of this lesion is not at all uncommon in angstpon, but if we go for an MRI, we can get to see. But the problem is that when we are doubting Pott spine in our mind, then it's difficult to challenge TNF inhibitors. So this poses a challenge in our clinical practice when we start off treatment. Case 2, this is a 55-year-old man with a neck pain, morning stiffness and an aggravation which is aggravating on some forward bending, also having some problem when he's trying to swallow, difficulty in deglutation, and this is the X-ray. It again feels that it's like syndesmophytes and ankylosed spine, but when we see the X-ray of the pelvis, we can see that there is no sacroiliitis. There are some enthesites also, the red pointers and the white arrows. These are suggestive of enthesitis, but there is no sacroiliitis. Without sacroiliitis, we cannot say a patient ankylosing spondylitis, whether the patient is HLB27 positive or anything else. So this is again a very close mimicry of angstpon. This is DISH. So DISH is again a condition in which the patient is present with back pain and neck pain, but no point giving any anti-inflammatories in these. So there is no sacroiliitis. It's basically an ossification of the ligaments of the spine, the anterior longitudinal ligaments in areas where they attach to the spine. According to the Resnick criteria, there has to be some anterolateral flowing ossifications of at least 4 contiguous thoracic segments, but there should be there's usually preservation of the intervertebral disc spaces and absence of apophyseal joint degeneration or sacroiliac inflammatory changes. So what is DISH is basically it is associated with old age, higher obesities, diabetes, but it's not associated with HLA-B27 positive. To confuse the whole thing, as I was showing in the picture before, DISH is associated with peripheral enthesopathies, and it's characterized by this bone spurs which I showed. But the ESR CRP levels will be totally normal. So if you get such enthesitis and angstpon, the ESR CRP should have shoot up. But with enthesitis with normal inflammatory markers, it's more suggestive of DISH, and we should carefully exclude it from angstpon patients. So the final takeaways, as I was saying, early diagnosis is important to prevent the disease, the patients to develop hyperkyphosis and impaired spinal movements. So, and as I was saying, the patient has to be, the onset of back pain has to be less than 45 years of age. Many times we have seen patients presenting in 55, 60 years. The problem of angstpon is many patients tend to tolerate the back pain and they tend to neglect or ignore it. So that is important. We have to stress, we have to ask the patient, do you have this, at least the main basic x-ray of the pelvis, this ESR CRP, because at least 10 years, we have seen many patients who are presenting late, but when we ask and when we press on the patients, do you have the back pain? Yes, they say that yes, it had onset, was definitely before 40 years. And the inflammatory back pain, as I already discussed. And first treatment is mostly NSAIDs. After 2 NSAIDs, we have to consider to shift to any of the 3 molecules, which definitely has to be considered, and the opinion of rheumatologist should be taken before starting. No medicine should be started without a good amount of monitoring. And definitely a good early and good treatment can prevent structural damage. And another thing is that a comprehensive care is very much important. We have seen many angstpon patients with mild disease can manage very well. Not only manage, the ESR CRPs also keep down well with just exercises and patient educations. So we have to educate the patients also well. And regular monitoring, regular assessment of the disease activity scores, which you have said, and of the complications is essential for optimal outcomes. With this, I would like to end my talk. Any questions you can ask me.
Yeah, Dr. Devanjali, very nice presentation. Thank you for that.
Thank you so much, sir.
I have got 2-3 things. First
Sure.
thing is, when we were starting this biological, specifically tumor necrosis factor alpha inhibitors, what is the end point of therapy? Number 1. How frequently do we need to, investigate or subject these people to X-rays or MRIs? Number 2. Number 3, what is the role of these DMRDs, which were there earlier? Because what you said is after the, NSIDs, straight you have to go for the 3 medications. So what is the role of the DMRDs? Or whether we should start this TML alpha in the beginning or give DMRDs and then, see for this? And when we can, end point of therapy for these, TNF alpha inhibitors?
Absolutely, sir. So I will give the answer the other way around, 3, 2, 1. So the question to your last question, the answer to the last question, the role of DMARDs. So there are 2 aspects. Most angstpon patients, they present with axial pain. As I was saying, 30% only present with peripheral joint pains. If the patient somehow has a lot of peripheral joint pains, peripheral arthritis, only in those situations can we offer sulfasalazine, methotrexate, leflunomide. In axial plane, there is no role of these DMARDs. So that is why I was saying, if the patient has axial pain, which we mostly see in angstpon patient, what the patient has, the troublesome complaint is the back pain only. So in those patients, after NSID, there is no role of trying any DMARDs. We can straight ahead go ahead with the either biologic or targeted therapies, which are the JAK inhibitors. So methotrexate will not help in axial pain, sulfasalazine will not help. But methotrexate recently has been found that can help in enthesitic pain, but not in the axial pain. No. So coming to no, not at all. So coming to the answer to a second question, which you asked whether we should be going ahead with any monitoring of the chest X-ray. So again, there is no role of monitoring the patient with on TNF inhibitors. Definitely what we see with TNF inhibitors, though we are giving a ATD in the initial 3 months or 6 months, whatever, it cannot protect the patient for a long time. For the duration, suppose we are giving the patient ATD for 3 months, Only for 3 months only the patient is protected from a new TB. So we are giving the TNF inhibitors even after that. Anytime the patient can develop tuberculosis. So that question will always be there, and that risk is always there if we are planning to continue TNF inhibitors. But still, we should be on the relying on the complaints of the patient. If the patient doesn't have any complaints, there is no role of repeated chest X-ray or any modality to look for whether the patient is developing tuberculosis. I will go. Now, the first question which I was asking, which is very important, that is, what is the end target treatment? So, ideally, by recommendation, and what the Western countries go ahead is it should be continued. That's what, when we were doing fellowship in Canada, we used to continue the patients. But there was not that much of a tuberculosis risk there. There are not much of a tuberculosis germs flying here and there as much as there in India. So there was hardly any, not much of tuberculosis flare also there. But in India, first of all, the cost comes. It's difficult to continue the patients for a long term. No Mediclaim can continue, and first of all, these are not much of included also. And the second thing is that if we continue it for a long time, there is quite a lot of chances of tuberculosis. So what we do in general in our practice is that we give the patients for at least 3-6 months. That is very much sufficient to sufficiently control the disease. And then either we stop it and see if the patient is flaring up. Then we keep it about monthly regimen. Like usual dose is 2 weeks regimen for adalimumab. We keep it relaxed at monthly regimen. If still not required, if the patient is exercising well, that can contain and maintain the remission for a long time. If the patient again has a flare after 1-2 years, we can again give it for another 2-3 months. So that is what we do in our clinical practice. And thankfully, in my last 5-6 years, whatever, not much of tuberculosis flare we have seen with this sort of a practice also. But 1 or 2 patients, what I've seen is like mostly we're getting 2-3 years of continuous, there is a risk of tuberculosis flare in our patients. Monitoring disease activity, first and foremost, is what the patient is saying. If the patient is saying that the back pain is definitely less, that is the most important factor. Apart from that, the other thing is that the inflammatory markers we follow. Again, we don't go on to see the repeat MRIs. So that is easy for us. CRP levels, if it's normal, near normal, we consider remission. Thank you so much.
Thank you, Dr. Debanjali.
Yes.
Yes.
My question is that in the TB regime, you told 3 months of rifampicin or 3 months, 6 months of rifampicin. Now we are in an era of eradicating TB from India. So, do you think it's going to increase the resistance rate in a community? And does it have the approval of any society? The regime you told us.
So, sir, we have seen, sir, TBs, just 1 or 2 doses of patients not received ATB and got a tuberculosis. We have seen it with our own eyes. After seeing that, it's difficult, sir, to not give ATDs to our patients. As I was saying, so we don't give for long-term TNF inhibitors. Anyhow, we are giving for 3-6 months and then we're trying to discontinue for some time. So, officially, there is no such guidelines in LTBI. That is very true. But it is risky, sir, if we are giving a mantle positivity without challenging even ATD, especially medically, it's very difficult.
Forgive me for interrupting.
No issue, sir.
Now, MAN2 at present in tuberculosis management is not a standardized practice. You know, in Indian scenario, MAN2 positivity of more than 10 and less than 20 is a very rare occurrence. Either it is less than 5 or more than 20. Both cases it has serious consequences and repercussions.
Yes.
So we have not taken MAN2 as a more standard guidelines to monitor the tuberculosis treatment. So taking MAN2 for managing these type of patients as a guidelines, I think quantiferon is a better.
Quantiferon is definitely better because, as I was saying, it's more sensitive. It doesn't cross-react. It doesn't cross-react with, if the patient has taken prior BCG strains, it also doesn't cross-react with NTMs, non-tubercular microvector, doesn't cross-react. So quantiferon is definitely takes about 1 week to come the reports. So otherwise quantiferon is preferred over Mantoux test definitely. And as I was saying, usually the onset of tuberculosis after giving TNF inhibitors is mostly biphasic. One we see is just after giving tuberculosis anti-TNF. So that we have seen. So some patients has come from outside, not received ATB. 2 doses of ATD anti-TNF, the patient developed tuberculosis. So after seeing these things, we are and then we give 3 months. I've seen for my patient also, I've given 3 months ATD, then the patient has stopped. Again, after 6 months, as I was telling, the TNF inhibitors was stopped. A gap of 6 months, then the pain had improved, aggravated. I gave TNF 1 dose and the patient had tuberculosis. That time again, we had not re-challenged ATD. So there is definitely a risk of TB. So we have to be careful and balance is needed.
Thank you, Dr. Debanjali.
Very detailed discussions of one of the not uncommon disease. Now ankylosing spondylitis is very common in our society. Regarding the reactivation of TB, whenever we say it is TB and it is reactivated, I think it is of the full course of treatment. Then this NATNF alpha to be instituted again. So thank you audience, and thank you madam for this nice topic.
There is a small token of appreciation. I will ask the chairperson to give it to Dr. Debanjali. I would also like to invite Dr. Rajanand sir on the stage to felicitate Dr. Debanjali. Oh, sorry. Now to felicitate the moderators, I would like to call Dr. Rajanand sir. Thank you, sir. Thank you, sir. Now the next session is symposium on ectopic fat syndrome. There are 4 speakers. As one of the speaker, Dr. H. Shubha from Bhadravati, she is absent. So I would like to call Dr. S.S. Patil instead of her. And other speakers are Dr. Juhi Datta from ISCO Banpur, Dr. Nagaraju from Vizag Steel Plant, Dr. Devashish Rai. Dr. Rajesh Maheshwari. Rakesh Maheshwari, इसमें pardon. Dr. Rakesh Maheshwari and Dr. Devashish Rai from Rourkela Steel Plant. I would like to invite the speakers on the stage at first. Please welcome Dr. Patil. Sir. Moderator, huh? Ma'am, take the stage. Chalo. And the moderators, Dr. Ashish Chatterjee sir from Durgapur Steel Plant, and also Dr. S.S. Patil sir, additional CMO from Durgapur Steel Plant. Now I am handing over the mic to the moderators, Dr. Ashish Chatterjee sir, to conduct the session.
Good afternoon, everybody. First of all, I will thank the Aismoc committee for selecting such a nice topic. It is a topic which is being discussed very often in different seminars, and it is a topic which is maybe the very crux of the problem of this metabolic syndrome, diabetes, insulin resistance, and so on. Now, fat, usually we know that when the fat exactly gets accumulated somewhere in the organs, like the liver, the heart or pancreas, or in the skeletal muscles, there are a lot of problems comes up. It will be discussed, and my esteemed friends will all speak about it. I will not say more, but I will now call Dr. S.S. Patil to start the.
Thank you, Dr. Ashish Chatterjee, sir. I have selected for this topic due to sudden demise of Dr. Sujit Kumar mother's death. Okay, so they both are not able to come here. Dr. Shobha is supposed to present this topic. So anyhow, I don't know how much justice I can do with this topic. Anyway, ectopic fat syndrome. It refers to the accumulation of excessive triglyceride in non-adipose tissues, and it occurs when subcutaneous fat storage capacity is exceeded. It drives insulin resistance, type 2 diabetes mellitus, cardiovascular disease, and inflammation. But the cause for adipose tissue dysfunction and ectopic fat storage is largely unknown. The most common site for ectopic fat deposition is visceral adipose tissues, liver, pancreas, skeletal muscle, followed by heart and kidney. In epidemiology, this disease is commonly associated with NFLD, type 2 diabetes mellitus, and cardiovascular disease. In risk factor, calorie surplus, obesity, and sedentary lifestyle is very much common. Men are more affected than women. In case of non-alcoholic fatty liver disease, the prevalence is around 6 to 35%. And in type 2 diabetes mellitus and obesity, the prevalence raised to 40 to 70% and 57 to 98%. In non-alcoholic fatty pancreas disease, the incidence is much more, 11 to 16%. And as it increases, the incidence increases of this disease. This is a normal fat metabolism. Diet and nutritional factor: high consumption of industrial fructose, usually found in sugar sweetened beverage, high intake of saturated fat, and lack of essential nutrients are commonly involved in this etiology. Inadequate physical activity, that is less than 150 minutes of aerobic exercise per week, prolonged sitting and sedentary time, and physical inactivity leads to reduced capacity of skeletal muscle to oxidize fatty acid. In lifestyle factor, poor sleep hygiene and chronic stress are another factors. In environmental factor, endocrine disrupting chemicals, environmental noise and pollution, and constant ambient temperature is another factors. In socioeconomic factors, easy access to cheap, high calorie food, and low income, low socioeconomic status, they eat whatever is available, and that increase the ectopic fat syndrome. A calorie intake that chronically exceeds energy expenditure in combination with low physical activity is the main cause of ectopic fat deposition in individual, in both with or without obesity. This is pathophysiology at a glance. As chronic overnutrition increases, it causes hyperinsulinemia and subcutaneous fat deposition, hyperplasia and adiposity. Overwhelming subcutaneous fat deposits, once they get spill over, the fat get accumulated in pancreas, liver, muscle, and other organ. In case of the cardiac health, ectopic fat accumulation around the heart or within the pericardium can lead to obesity-related cardiomyopathy. And lipid oversupply to the cardiomyocytes causes mitochondrial dysfunction, inflammation, and compromised cardiac function, ultimately contributing to heart failure. Ectopic fat accumulation in the liver causes non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, and cirrhosis. Insulin resistance is another very alarming factor. Skeletal muscle adiposity, including intramuscular and intermuscular fat, causes insulin resistance. Renal lipid accumulation and lipotoxicity play a crucial role in development and progression of chronic kidney disease. Pancreatic fat accumulation can lead to non-alcoholic fatty liver disease, which may contribute to inflammation and beta cell dysfunction. Thank you very much, sir.
Thank you, sir. Is there any question from last day? The next speaker is Dr. Juhi Datta. She will discuss about the pediatrics.
Respected chairpersons, seniors and delegates, my part is a pediatric population having this ectopic fat syndrome. I am Dr. Juhi Datta, consultant in Burnpur Hospital. So ectopic means other than adipose tissues, fat is getting deposited in different parts of the body. Why are we concerned? Because fat around the body, role of fat is good, but too much fat in fat tissue, bad. And fat in non-fat tissue is ugly. And the prevalence of the overweight children under 5 has increased from 2.1% in 2015-16 to 3.4% in 2019 to 21. And Indians as an ethnic group, they are particularly at high risk for this insulin resistance, central obesity, syndrome X, which actually causes the metabolic complications. The diagnosis of obesity is based on body mass index. This obesity is the most common nutritional disorder affecting the children and adolescents in the developed world as well. 50 to 80% of the obese children become obese adults. Thus, we have to screen them when they are child. The criteria for diagnosis is body mass index after 2 years. But before that, we need to take the graph of this height and weight growth chart, and more than that, the body mass index growth chart that we plot over here. Weight for height below 2 years, if more than 97th percentile is obesity. Other parameters being skin fold thickness, waist circumference, waist hip ratio. Waist circumference more than 95% is a very high risk factor for complications. Body mass index above 5 years, we can take the adult equivalent of BMI more than 23 to be overweight, and more than 27 is the obesity, which we plot in these growth charts. Etiology, 95% is constitutional, but we have to rule out the 5% which can be pathological. Endocrine causes, or it is genetic syndromes. They are usually also associated with short stature. Thus, normal height with obesity more going towards constitutional cause. Other causes being any drugs like anti-epileptic steroids, or any monogenic disorders like leptic deficiency or melanocortin receptors, which may cause the suppression of the satiety center and hyperphagia, causing obesity. The evaluation, first and foremost, we have to differentiate between the constitutional and the pathological. Firstly, the pattern, generalized obesity in constitutional, central in pathological, along with growth, which is retarded in pathological. Constitutional, it is accelerated with dysmorphism and endocrine features suggest toward the pathological causes. Along with it, detailed family history, physical activity, diet chart needs to be taken. These are the different, if there are many symptoms associated with obesity, the syndromes need to be ruled out. So investigations, first and foremost, no workup is required if the child has normal growth, normal faces, development and pubertal development is normal. In fact, in girls, in obesity, pubertal development is accelerated while it is delayed in obese boys. Because they will have mildly elevated TSH, mildly elevated cortisol, no need to work up. But if we are suspecting pathological, definitely extensive workup with thyroid profile, cortisol levels, genetic testing needs to be done. And the complications like HbA1c, lipid profile, liver function test, blood pressure needs to be also monitored. Now considering the 95% of the constitutional weight gain in children now, because of the disbalance between the energy in and energy out, where high caloric density food is being taken in. The vicious cycle of sedentary work style making a healthy child to mildly obese, more sedentary and more laziness causing moderately obese child, more laziness is causing severely obese child and thus leading to with comorbidities. So the factors which are causing overeating, easy accessibility, low cost, good taste, and also the sedentary lifestyle is causing this obesity. And 60% of the child who are overweight before puberty will be overweight in early adulthood as well. There are many complications with central nervous system, growth, sleep, cardiovascular, metabolic associated with obesity. Management. The first management is when the child will step in the OPD. If we find any disproportionate, we have to plot it in the BMI chart or the height and the weight chart according to the age. If it is, we have to start prevention and other steps accordingly. First is a general approach. Generally, it should be small, gradual, permanent changes. Reduce calorie, increased activity, decrease sedentary behavior. Family needs to be involved in it. Early intervention, though not more earlier than 3 years. And we as a doctor should be encouraging as well. Medical goals, all the comorbidities needs to be ruled out. Eating healthy is very important factors without dieting because that will compromise nutrition and vitamins. Medical management, if the BMI is crossing 27 with comorbidities or crossing 30 BMI. The key points is from the first day, promotion of breastfeeding, age-appropriate portion size of meals and snacks, screen time to be limited, physical activity to be promoted. As a pediatrician, short stature is an obese child. That will suggest a pathological cause. As I said, obese girls have early puberty and boys will have delayed. And one important thing, now there are many small for gestational age children. They will develop the complication at a lower weight than those with normal size at birth. So they have smaller store for fat. So they are at more high risk for future obesity. In short, genetics loads the gun, but lifestyle pulls the trigger. There is no better time than now to start healthy living. Thank you.
Now I invite Dr. Rakesh Maheshwari for cardiometabolic aspect.
Very good afternoon to chairpersons and delegates. I am Dr. Maheshwari from RINL Visakhapatnam. I am covering cardiometabolic effect in ectopic fat syndrome. As previous speaker shows that ectopic fat refers to abnormal accumulation of triglycerides in non-adipose tissue such as liver, skeletal muscles, pancreas and heart. When subcutaneous depots become saturated, excess free fatty acid spill over into the organs leading to the lipid storage where normally it should not be. Pathophysiological impact of this is liver overload causes lipotoxicity, impaired insulin signaling, triggering oxidative stress and chronic inflammation, lead to insulin resistance and metabolic dysfunction. Clinical relevance of it is ectopic fat accumulation contribute to metabolic syndrome, type 2 diabetes and cardiovascular diseases. It is better predictor of cardiometabolic risk than BMI or total body fat. focus now shifts from how much fat is there to where the fat is located. Ectopic fat is metabolically dangerous form of fat. So what is the difference between normal and ectopic fats? Subcutaneous fat, that is normal, it acts as a safe energy reservoir, secretes protective adipokinins and maintain insulin sensitivity and metabolic homeostasis, associated with metabolically healthy obesity when functioning properly. Visceral and ectopic fats located in the visceral cavity, liver, pancreas, skeletal muscle and heart. It has high lipolytic, releases free fatty acid directly into the portal circulation, produces pro-inflammatory cytokines, reduces adiponectin, promote insulin resistance, endothelial dysfunction and atherogenesis. So what is the difference between these two? So visceral or ectopic fats is metabolically active and pro-inflammatory, and it is more harmful. It secreted tumor necrosis factor and interleukin C, and there is a strong relation with CVD. So visceral adipose tissue located within the abdominal cavity surrounding internal organs, highly metabolic active and releases free fatty acid directly into the portal when strongly linked to insulin resistance and dyslipidemia and coronary artery diseases, lead to coronary artery diseases. Hepatic fat, that is liver steatosis, accumulation of the triglyceride within the hepatocytes lead to non-alcoholic liver disease and progress to NASH. Increase hepatic insulin resistance and contribute to the systemic inflammation. So myocardial fat, that is epicardial, pericardial and intramyocardial. Epicardial fat adipose tissue between myocardium and visceral pericardium shares coronary microcirculation, exert paracrine effect on the heart and inflammation, fibrosis and arrhythmia risk. Pericardial fat also correlates with the coronary calcification and atherosclerosis. As far as pancreatic fat is concerned, accumulation of the fat in pancreas and parenchyma and around islets causes beta cell dysfunction, impaired insulin secretion and contribute to glucose intolerance. Skeletal muscle fat, that is intramyocellular and intermuscular fat accumulation within the muscle fiber interferes with insulin-mediated glucose uptake. It strongly predicts insulin resistance and type 2 diabetes mellitus. Renal and perivascular fat promote vascular inflammation and endothelial dysfunction. Renal sinus fat linked to the hypertension and CKD progression. So each ectopic fat depot has distinct local and systemic cardiometabolic effect, but all shares common pathophysiology of lipotoxicity and inflammation. So pathophysiological overview is that overflow hypothesis, in which when subcutaneous fat reaches its storage limit, excess circulatory free fatty acid overflow into the non-adipose tissues like liver, heart and muscle, as I told you. This leads to the ectopic lipid depot and metabolic stress in this organ. Another is adipocyte hypertrophy and dysfunction. Enlarged adipocytes become hypoxic and inflamed, recruiting macrophages, and secretion of pro-inflammatory and cytokines increases, and adipokine imbalance occur, that is low level of adipokines, high leptin and resistin, worsening insulin resistance. Another is lipotoxicity. Excess intracellular fat, free fatty acid forms toxic lipid intermediates, that is ceramide, that is very difficult to metabolize, and diacylglycerol. These impair insulin signaling pathway. Lipid-induced cellular stress, intracellular accumulation of the ceramide and DSC disrupt insulin receptor signaling, induces endoplasmic reticulum stress and oxidative stress via mitochondrial overload, result in myocyte apoptosis and fibrosis, leads to diastolic dysfunction and heart failure with preserved ejection fraction. Mitochondrial dysfunction. Overloaded mitochondria produces excess reactive oxygen species. Reactive oxygen species amplify local inflammation and impair fatty acid oxidation, create a cycle of metabolic inflexibility and tissue injury. Endothelial dysfunction and atherosclerosis. Inflammatory mediators reduces nitric oxide availability, promotes vascular stiffness, plaque formation and atherothrombosis. Key key takeaway is molecular cascade form adipocyte dysfunction, cytokinin release, lipotoxicity, the link between ectopic fat and insulin resistance and cardiovascular diseases. Another entity is myocardial steatosis. It is intramyocardial accumulation of triglyceride in cardiac myocyte. Lipid overload lead to lipotoxicity, mitochondrial stress, and disrupt insulin signaling. This lead to myocardial insulin resistance, promote fibrosis and adiposis. Clinical effect is diastolic dysfunction associated with obesity, type 2 diabetes mellitus, and metabolic syndrome. May cause increased arrhythmia due to structural remodeling, and imaging that is used is proton magnetic resonance spectroscopy, CT attenuation, and key takeaways myocardial steatosis links metabolic dysfunction directly to the cardiac disease and even in non-obese diabetes patients. Vascular effect is surrounding blood vessels normally protect, but inflamed perivascular adipose tissue releases cytokinins, promote endothelial dysfunction, reduces nitric oxide. Atherogenosis lead to plaque formation and instability. Direct paracrine effect on adjacent arterial contribute to the CAD progression. Clinical imaging use is CT-based fat attenuation index, and key point is vascular adipose tissue is an active endocrine organ linking metabolic dysfunction to the atherosclerosis. It is already covered by previous speaker. So diagnostic evaluation is CT computer tomography quantifies visceral fat, epicardial fat, and perivascular fat. Fat attenuation index predict coronary inflammation. Magnetic resonance image is gold standard for hepatic, myocardial, and pericardial fat quantification. Proton MRS measures intramyocellular and intramyocardial triglycerides. Echocardiography measures epicardial adipose tissue, and thickness more than 5 mm leads to higher CAD risk, and positron emission tomography detects metabolically active and inflamed fat deposits, useful for research and assessing therapeutic intervention. Biomarker is circulating lipid and free fatty acid. Elevated FF will reflect lipid spilling over from subcutaneous to the active depot, contribute to the insulin resistance. Adipokinins decrease adiponectin and increase leptin and resistin. Inflammatory cytokinins such as TNF, ILF, and MCPI. Emerging biomarkers are fatwin A, FGF21, and irisin. Therapeutic intervention is dietary modification, physical activity, weight loss, and clinical insight. Pharmacological interventions are pioglitazones that leads to redistribution of fat from visceral to ectopic deposit to the subcutaneous tissue, improve hepatic steatosis and insulin sensitivity. GLP-1 receptors reduces visceral and ectopic fat, improve glycemic control, weight loss, and cardiovascular outcome. SGLT2 inhibitors decreases epicardial and pericardial visceral fat, improve myocardial metabolism, and reduces heart failure risk. Other agents are statin. Key point is pharmacotherapy complements lifestyle interventions and reducing ectopic fat and improving cardiometabolic outcomes. Bariatric surgery. Effect on ectopic fat is rapid reduction in hepatic, visceral, and epicardial fat, improves insulin sensitivity, metabolic profile within months. Cardiac benefit is enhanced left ventricular diastolic function, improves cardiovascular risk beyond weight loss alone. Metabolic outcome is that decreases blood glucose, triglyceride, and inflammatory markers, can lead to remission in type 2 diabetes in selected patients. Bariatric surgery is powerful intervention for high-risk patients with morbid obesity and ectopic accumulation.
Sorry, Doctor, interrupting you. You are exceeding the time.
Okay.
And I think this treatment part will be covered by Dr. Debashish Ray, our next speaker from Rourkela Steel Plant. Thank you, Dr. Rakesh Maheshwari.
Good afternoon, respected chairpersons and all the delegates. To continue with the topic, as various aspects have been already covered, so let us discuss about the management part. So, ectopic fat syndrome management, it is a comprehensive exploration of advanced strategies to address abnormal fat deposition and restore the metabolic health through targeted interventions. So, just a brief introduction. Ectopic fat represents the abnormal fat accumulation in organs where it doesn't belong, such as the liver, pancreas, heart, skeletal muscle, kidneys. Unlike subcutaneous fat stored safely beneath the skin, the ectopic fat directly disrupts the organ function through mechanisms involving chronic inflammation and insulin resistance. So there is development of hepatic steatosis, deposition of epicardial fat and intramicellar lipids. So why ectopic fat matters? Because of its metabolic and cardiovascular risk. So it serves as a powerful driver of metabolic dysfunction, promoting insulin resistance, beta cell dysfunction and chronic systemic inflammation. So there is development of insulin resistance, chronic inflammation, beta cell dysfunction and cardiovascular disease risk like increased atherosclerosis. So the goals of the management, it lies, there is four thing, to reduce the ectopic fat deposition, to enhance insulin sensitivity, to reverse the metabolic dysfunction and prevent end organ damage. So there is mounting clinical evidence demonstrating that reductions in the ectopic fat correlate more strongly with metabolic improvements than overall weight loss alone. As cited here, various studies, the bariatric surgery and hypocaloric dietary interventions can rapidly reduce both liver and pancreatic fat. There is approximately 30% liver fat reduction seen with intensive lifestyle intervention over 12 weeks, 40% pancreatic fat loss post bariatric surgery within 8 weeks, and 85% insulin sensitivity improvement following ectopic fat reduction interventions. Lifestyle modifications, it forms the cornerstone of ectopic fat syndrome management. There should be dietary optimization. Mediterranean and low glycemic index diets show superior efficacy in reducing hepatic and pancreatic fat. Calorie deficit of 500 to 750 kilocalorie per day targets the ectopic deposits while preserving the muscle mass. Physical activity, regular aerobic exercise combined with resistance training programs improves muscle insulin sensitivity and reduces visceral fat. Aim for 150 to 300 minutes of moderate intensity activity weekly. Adequate sleep of 79 hours and stress management through mindfulness reduces the cortisol driven ectopic fat deposition and improve metabolic parameters. The available pharmacological options, the recent pharmacological innovations have transformed our ability to specifically target the ectopic fat deposits. We have GLP-1 receptor agonists like semaglutide, liraglutide and dulaglutide. They reduce epicardial fat and hepatic fat by 20 to 35% and improve cardiovascular outcomes and induce significant weight loss. SGLT2 inhibitors like dapagliflozin, empagliflozin, canagliflozin, they decrease epicardial fat thickness, reduce cardiovascular and renal events and lower blood pressure. Dual agonists, tirzepatide, a novel dual incretin mimetic drug. Benefits like superior ectopic fat reduction, particularly in fatty pancreas and kidney diseases. Pioglitazone, it stimulates PPAR gamma receptors. Benefits like improvement in metabolic parameters and reduction of hepatic steatosis. Statins like HMG-CoA reductase inhibitor, highly effective for treating dyslipidemias and preventing the progression of MSLD. Saroglitazole, it is a dual PPAR alpha and gamma agonist indicated in diabetic dyslipidemia, hypertriglyceridemia, NFLD. So it is a newer drug, resmetirom, reference taken from the API update to 2025. Though it is in trial phase in India, it is a agonist of thyroid hormone receptor beta, receptors in the liver hepatocytes. Indications are like treatment for adults with metabolic dysfunction associated steatohepatitis and moderate to advanced liver scarring in stages like F2 and F3. It has potential future indications like heterozygous familial hypercholesterolemia with some adverse effects, and it is contraindicated in decompensated cirrhosis. Coming to the surgical options, though endoscopic, minimally invasive endoscopic procedures are favorable nowadays, like intragastric balloon and etc. The patient criteria is patients with BMI more than equal to 35 with comorbidities or BMI more than equal to 40 with failed conservative management and absence of contraindications. There is significant reduction in ectopic fat within 4 to 8 weeks post procedure and restoration of insulin sensitivity. So the challenges, there lies some challenges like need of newer imaging innovations, developing accessible cost-effective methods to measure ectopic fat in primary care setting like point-of-care ultrasound applications, AI-enhanced image analysis, portable MRI technology. There is need of personalized medicines like genetic profiling for ectopic fat risk, metabolomic guided therapy, and individual depot targeting strategies. Also need of some novel therapeutics like triple agonists, selective PPR modulators, mitochondrial function enhancers. So the concluding, the management lies on 4 pillars like lifestyle foundation, pharmacological targeting, surgical innovations, and a precision approach. So the key takeaway is the future of metabolic disease management lies not in focusing solely on weight or BMI, but in precisely targeting the ectopic fat depots that drive organ dysfunction by integrating lifestyle modification, advanced pharmacotherapy, and surgical intervention when appropriate. We can achieve meaningful remission and restore the metabolic health for millions of people worldwide. This is just a reference from the Harrison. So with BMI when goes over more than 30, so there is a need of both pharmacotherapy and surgical intervention. Thank you.
Thanks to all the speakers for such a nice presentation. Now it is open for questions. Anybody from the audience want to ask, please?
Myself, Dr. Navnil, RSP. I want to ask that how beneficial and rational is using semaglutide, liraglutide in our setup in managing obesity?
So basically, the management management strategy is individualized based on age and other comorbidities and most important available resources. So the GLP-1 receptor agonist semaglutide, they are definitely costly. So it has basically mechanism of action like it slows the gastric emptying, induces early satiety and reduces appetite. So in due course of time, it leads to that weight loss. But there should be advice to avoid binge eating. Basically, the drug is like that you are paying to not to eat. So if along with the medication, if the binge eating continues, then there is no such benefit.
Anybody else? None. Okay.
So
I
my one query is, it is a cost is a factor.
Yes.
Suppose cost is not a factor, then should it be used? Is it as of now? Is it a recommendation through the anybody other than diabetes for obesity only?
So that is two varieties there. That Ozempic and another is Wegovy. So that initially if a patient is pre-diabetic and who is pre-diabetic and wishes to reduce the weight, then that Ozempic is used to started with very low dose, and in due course of time there is improvement in the euglycemia and also there is weight loss. So basically it is individualized and the treatment is individualized based on patient preference and also there is a possible side effects. There is a lot of side effects like that delayed gastric emptying. So it leads to a lot of gastric discomfort like nausea and etc. So the patient compliance is also a factor. So if all the things come together, then it is better treatment option.
question? No. And Dr. Patil was saying about the endocrine disruptors. And I will ask you, any of the speaker, how far it is affecting the ectopic fat, endocrine disruptors, and what are the measures to be taken?
So the question has been.
He was talking about the endocrine disruptors as a factor for ectopic fat. Okay. Now, I want to ask how far this is affecting.
So what?
How far?
Thank you for the question. As in pediatric population, 5% is pathological reasons for the obesity. In that, endocrinopathy is one of the important causes of obesity, where the different causes are hypothyroidism, pseudo-hypoparathyroidism, Cushing syndrome. These are the causes where obesity is a part of it.
Okay, thank you very much. Any other question? No. Then we will conclude here. Thank you very much.
I would request Dr. Ashish sir to felicitate our speakers. First, Dr. Patil. Dr. Juhi Datta. Dr. Debashish Rai. Dr. Patil sir. And I would request Dr. B.B. Korunami sir to felicitate Dr. Ashish. Thank you all. Now we are proceeding to next session. The next session is on recent advancement and upcoming drugs in nephrology by our guest speaker. I would like to request Dr. Upal Sengupta, MDTM Nephrology from Fortis Hospital on the stage. To chair this session, I would like to invite Dr. Jayant Kumar Acharya, CMO IC Rourkela Steel Pan, and Dr. Ajit Karmakar, additional CMO Durgapur Steel Pan. Dr. Upal Sengupta is a consultant nephrologist and transplant physician in Fortis Hospital. Oh, Manipal, sir. In Manipal Hospital, he has 22 years of experience in medical services, preventive health management, and administration in nephrology and renal transplantation. He passed MBBS from Medical College, then MD Internal Medicine from PGIM Chandigarh, DM Nephrology from the same institute thereafter. He is member of different national and international societies of nephrology and author of different books and national and international journals. I will request Dr. Upal Sengupta for the speech.
Thank you, organizers. Thank you, chairpersons. It's not possible to develop recent updates in nephrology in this small time. Whatever we'll discuss is recent upcoming drugs in nephrology. That was my idea, to put forward with upcoming drugs in nephrology. What is interesting and how beneficial clinically they're going to be in coming years. In coming years, the practice of hypertension and nephrology is going to see major changes in the way we treat the hypertensive patients with or without organ dysfunction. So nephrology and hypertension is an interchangeable problem. We are, as a nephrologist, before that as a clinicians, we are yet to see patients of nephrology having kidney dysfunction who are not hypertensives, and again vice versa, hypertension poorly controlled will give rise to kidney disease and problems of nephrology. So we all know about the basics of renin, angiotensin and aldosterone axis. The basic hormone is renin, which is released from the kidney, and then the angiotensinogen, which comes from the liver, and then renin cleaves it to angiotensin 1, and then AC inhibitors, AC is angiotensin converting enzyme to angiotensin 2. We know all this basic pathophysiologies. Angiotensin 2 directly act on the blood vessels and vasoconstriction, and also importantly give rise to the secretion of aldosterone. Downstream, aldosterone causes a lot of pathophysiological effect when secreted in excess in heart, in kidney, as well as in blood vessels. So a lot of organ dysfunction that we see in hypertension and uncontrolled blood pressure is due to excess amount of downstream angiotensinogen and again the amount of aldosterone. So what we knew about RAS system inhibition before these days were age-old drugs of AC inhibitors and ARB we've been using for past 20 years. Now MRA, middle cortical receptor antagonist, those receptors on which aldosterone act, like spironolactone and eplerenone, they were there for a long time, especially spironolactone, especially used in heart failure and also in refractory hypertension. Now we have seen the emergence of non-steroidal mineralocorticoid receptor antagonist in finerenone. I'm starting after finerenone. We all know about AC, ARB, mineralocorticoid receptor antagonist, eplerenone and spironolactone and finerenone. What is after finerenone is, if you concentrate on this pathway, so renin, angiotensin 1, 2, and then again aldosterone, what happens if we block the synthesis of aldosterone? So the drugs, most promising upcoming drug of treatment of resistant hypertension is aldosterone synthase inhibitors. Aldosterone synthase inhibitors, they preferentially stop synthesis of aldosterone downstream, do not stop or inhibit synthesis of cortisol. So aldosterone synthase inhibitors or ASI are undergoing phase 3 trials now. What are the drugs? Baxdrostat. The trials, important trials are BRIGHT hypertension trials where they have taken refractory hypertensive patients already on 3 drugs. So use of Baxdrostat over and above all these things cause a dose-dependent fall in blood pressure, systolic blood pressure. Again, then BAX hypertension trial is a large global trial in uncontrolled and resistant hypertension. Baxdrostat 1 to 2 milligram once a day added to standard therapy gave significant systolic blood pressure reduction versus placebo and acceptably safe in early reports. So the refractory hypertension, what we had earlier, we have an upcoming drug in our armamentarium is the aldosterone synthase inhibitor. One of them is Baxdrostat, one of other is lorundrostat. is target hypertension trial. They've also seen that with this in resistant hypertension, over and above the standard therapy of more than 3 drugs, it caused significantly more reduction of systolic blood pressure as compared to placebo over and above the standard therapy. Are they beneficial in CKD? Yes, this molecule, they have not revealed the name. They have undergone a phase 2 trial. They have shown that it is beneficial in CKD as well, with more than 20% reduction of UACR and blood pressure control. So aldosterone synthase inhibitors are the most common upcoming drugs, most promising upcoming drugs coming in the field of hypertension and nephrology. So if I ask the audience or the chairperson, I need help, what is the biggest problem with antihypertensive therapy? Can anybody answer? What is the biggest problem with antihypertensive therapy? If I need a one-word answer, what will be the answer, sir?
Compliance.
Exactly. This is what I meant to say. The long-term compliance of antihypertensive drugs is the biggest problem. Patient won't take drugs. So imagine a drug, an antihypertensive drugs, which is injectable, and you have to take it once in 6 months. How would that be? A landmark and a practice-changing thing. So it is coming. The technology is known as the siRNA technology. The drug name is zilebesiran. So what zilebesiran is a combination of 2 strands of complementary RNA that are labeled as galactomannan and acetylgalactomannan and are taken specifically by hepatocytes. Inside the hepatocytes, they are modified and they inhibit the synthesis of angiotensinogen. Once injected, they inhibit the synthesis of angiotensinogen for 6 months with good amount of BP reduction without any antihypertensive drug and above and other antihypertensive drugs. So there are trials. So the RNA inhibitor against angiotensinogen, zilebesiran, subcutaneous RNA interference target hepatic angiotensinogen, allowing 2 to 3 times a year dosing. The phase 2 cardiac trial showed sustained 3 to 6 months systolic blood pressure reduction when added to standard therapy. Phase 3 cardiovascular outcome trials are being launched and being conducted. We hope these drugs, the lipid-lowering drugs of this type are already in place, that they are getting research, but this antihypertensive drug, zilebesiran, we hope to come in practice in another 3 to 4 years, which will probably be a practice-changing drug in hypertension. So, new and upcoming drug in diabetic kidney disease. So we are going beyond SGLT2 inhibitor. Again, we are going beyond non-steroidal mineralocorticoid receptor antagonist, which is finerenone. So we all know about the GLP-1 receptor agonist. We are treating diabetes, we are treating obesity with GLP-1 receptor antagonist. But nephrologist for a long time has eyes on these molecules. These are potentially kidney benefiting molecules. So they have done a number of trials with different eGFR category of patients being included in the trial, but none of the trials before the FLOW trial have arrived targeted the renal population specifically. It is like something we have seen in DEPA CKD and EMPA kidney trial. Now they have a trial of GLP-1 receptor analog therapy in CKD patients, diabetic and non-diabetic CKD patients. We can even use this drug in non-diabetic CKD, not only for obesity, but the reduction of progression of CKD, but the same way use SGLT2 inhibitor. So the FLOW trial, that showed that major kidney events at a significant lower HR of 0.76, death due to any cause in CKD patients is 0.8 reduction, and adverse event was minimal, not separate. So you can use GLP-1 receptor analog beyond diabetes, beyond obesity, only in CKD patients as a conjugate, as an add-on therapy to whatever standard therapy and SGLT2 inhibitor. This is being promoted in the guidelines as well, and is a standard therapy for diabetic as well as non-diabetic CKD. So what about SARPAS 4 trial? We all know about the drug known as Mounjaro. Mounjaro is a combined GLP and GIP-1 receptor analog, again being widely advised to treat obesity and diabetes. This trial, the SURPASS 4, the latest of the SURPASS group of trials, again showed that the molecule tirzepatide showed slower kidney function decline compared to insulin glargine over 85 weeks. The significant albuminuria reduction, you can see 6.8% versus almost 37% reduction and 42% risk reduction of composite kidney outcome, although not comparable, even more than SGLT2 inhibitor. So the dedicated trial for Monjuro for kidney disease is coming up, but the data from the SURPASS trial, which had a significant number of CKD patients, shows very promising result that in diabetic as well as in non-diabetic CKD, Monjuro, like the previous GLP-1 receptor analog, which is Ozempic and Wegovy, is going to be very helpful. What is latest is the triple drug inhibitor. We were discussing about GLP-1 receptor analog, which is Wegovy and the Ozempic. Then we had combined GLP-1 and GIP-1 receptor analog, which is Monjuro. Now we have retatrutide, which is combined GLP-1, GIP-1 and glucagon receptor antagonist. This drug is being seen in a cohort comparing type 2 diabetes and obesity and CKD without diabetes. It's been seen that in patients without diabetes, the effects are more. Even it has increased the GFR to 5.3 ml per minute per 1.73 meter square, almost 28% reduction of UACR, and this effect is obviously more in obese CKD patients as compared to diabetic CKD patients. So this triple drug analog is also going to come in the treatment of diabetic as well as non-diabetic CKD. So we have discussed till now about the hypertensive, newer antihypertensives and the GLP-1, GIP and glucagon receptor analogs in the treatment of kidney disease, upcoming drugs in the treatment of hypertension. So now we come to hardcore nephrology, IgA nephropathy. IgA nephropathy is one of the most common, not one of the most common, it is the most common glomerulonephritis in India. It's been the most common glomerulonephritis causing chronic kidney disease, diagnosed or undiagnosed in India. So what is the baseline therapy of chronic the IgA nephropathy? The standard therapy for IgA nephropathy is depending on the staging it has. Staging means the risk of progression it has. A mildly progressive disease is treated only with AC inhibitors or ARB and SGLT2 inhibitors. Depending on the risk of progression, we add on immunosuppression, be it steroid, oral steroid or a TRF locally released, colonic released budesonide or as compared to systemic steroid, mycophenolate mofetil, sometimes tacrolimus. These were the standard therapy of IgA nephropathy. Now this sibeprenlimab is an antagonist of April. So what is April? April is a proliferation ligand that is seen in IgA nephropathy to be the most common cytokine that causes proliferation of beta cells that produce difficult and defective IgAs that are the basic of IgA nephropathy. So this is sibeprenlimab in IgA nephropathy. This trial by Vlado Petrovic and Professor Jonathan Barrett, who are legendary figures for IgA nephropathy, they have shown there's a significant reduction of proteinuria. So this is in short a pathophysiology of IgA nephropathy. Defective IgA molecule are being synthesized from gut mucosa. It's a disease of gut mucosa, and unfortunately this defective IgAs, they got polymerization and they get deposited in the kidney causing IgA nephropathy. So the onset of the disease is in the gut, the mucosal associated lymphoid tissue, and the drugs to treat them is, one of the drugs to treat them is locally released budesonide, which you give orally, will go to colon and get deposited there and release and decrease the inflammation in the Peyer's patch. So other than locally active budesonide and other than reducing kidneys inflammation by systemic steroid or mycophenolate mofetil, this April or BAFF inhibitor, which is sibeprenlimab, has shown a significant decrease in proteinuria. So if you see in this trial as compared to placebo, different doses of sibeprenlimab, the 8 milligram dose of sibeprenlimab has significantly decreased the protein creatinine ratio in active IgA nephropathy patients, and this drug has already been approved this year by FDA for treatment of IgA nephropathy. So this is the way sibeprenlimab, the rising dose of sibeprenlimab benefits the patient of IgA nephropathy, reducing the protein creatinine ratio and also increasing the GFR decline as well. So what are DRA? These are the drugs coming in big way in the treatment of hypertension and many other kidney disease. These are dual endothelin angiotensin receptor antagonist. One molecule which is antagonist to endothelin receptor as well as the angiotensin receptor. So what are the drugs? Sparsentan, artesunate are the most common drug. So again used in IgA nephropathy, sparsentan versus an ARB, irbesartan has shown a significantly more reduction of proteinuria in active IgA nephropathy. You can see the degree of proteinuria 50% versus 15.1% as standard therapy like irbesartan, which is an ARB. Again, alone, artesunate reduces the proteinuria by 54.7%, which is also a DRA. The artesunate versus placebo trial is, aligned trial is ongoing, but the initial reports are extremely optimistic that they reduce the amount of proteinuria, and reduction of proteinuria is a very important step that predicts and prevents the progression of IgA nephropathy to a chronic disease. So DRA, dual endothelin and angiotensin receptor antagonists, are coming in a big way in the treatment of chronic glomerulonephritis, mainly IgA nephropathy. So this is also the trial artesunate in patients with IgA nephropathy, recently published October 25 in New England Journal of Medicine. The geometric mean percentage change in the urinary protein creatinine ratio relative to the baseline was significantly greater with atrasentan than placebo, with a geometric mean between -36% to -44%. My last drug will be on something which have read from a pathology days. Complements. Complements, we have tested and treated many patients of complement related disorder. C3, C4, we have known C3, C4 mainly in lupus nephritis, or pediatrician test it for in post-infectious glomerulonephritis. But complements are coming in big way in pathophysiology of many glomerular kidney disease, namely complement related HUS, atypical HUS disease, complement related glomerulonephritis and C3 glomerulopathy. Even IgA nephropathy has a significant amount of component which is mediated by complements. You will be surprised to know even diabetic nephropathy has component of complement. So this drug, iptacopan, is a factor B inhibitor which prevents the downstream activation of the complement pathway. This phase 3 trial in IgA nephropathy has shown significant reduction of proteinuria and disease activity in IgA nephropathy. Complement drugs, avacopan, iptacopan, which is an orally tablet complement inhibitor, factor B inhibitor, is coming in a big way in treating complement related kidney disease, and the spectrum of complement related kidney disease are increasing day by day. Initially it was limited to SLE or limited to post-infectious glomerulonephritis. Now we'll know that IgA nephropathy, diabetic nephropathy, atypical HUS, all are related to C3 glomerulopathy, all are related to complement-related disorder. And these complement inhibitors, orally active complement inhibitors, are going to change the course of the disease, which eventually leads to CKD, will prevent CKD. I'll stop my discussion over here. We have discussed this much of new and upcoming drugs, which will probably change the course, the way we treat hypertension, diabetes, diabetic kidney disease, and different glomerulonephritis. So we won't arrive, definitely we have not arrived. It's an endless search. The search for new upcoming drugs will always be there, and there will always be new advancement, like the epoch-making change in once in a year or twice in a year therapy of hypertension. Thank you.
Thank you, Dr. Upal Sengupta, for a nice presentation. And the best part of it was like getting a hypertensive shot, like a Botox shot, once in every 6 months. Then it will become something like just go for a vacation, have a shot and come back and enjoy your days. So that was one of the very interesting things. And like complement targeting, there is something called eculizumab in C5. So I thought that...
So eculizumab I have not discussed because we are already using eculizumab for a long time now. Eculizumab is available in India. Earlier we used to import eculizumab in treating the disease. Now it's available in India. So I have not discussed eculizumab because I thought it's a drug already
in the market.
Yeah.
Okay. Thank you. Any questions from audience? Yes, sir. Please come up.
For children, for IgA nephropathy with hypertension, which drug you suggest the best?
I do not treat children with hypertension. For the adults with IgA nephropathy, the drug that treats the hypertension and treats the kidney disease is the ARB and ACE inhibitor, first line drug. Along with SGLT2 inhibitor, these three are first line drugs. Along with, you have to decide on immunosuppressive therapy depending on the risk of progression. Right?
Please identify yourself.
Sir, am I audible?
Yeah.
Very good evening, sir. Myself, Dr. Mohit, Senior Medical Officer, Department of Neurosurgery, Bokaro General Hospital. Thank you for such an informative presentation, if I may say so, sir. Sir, I just wanted to ask a question about a patient I know. The patient is a diagnosed case of FSGS.
Right.
And she is 20 to 22 years old, female. She is a trainee nurse in our hospital.
Yes.
What happened to her, sir, is that to the best of my knowledge, 1 or 1.5 years back, she was started on antihypertensives. But within a span of 15 to 20 months, she had to take rituximab, and then now she is waiting for transplant.
Right.
So what I wanted to ask, sir, as these drugs are on trial, and as you explicitly mentioned, that some of them can delay the progression of diseases such as IgA nephropathy and etc. to CKD. Can that, will that drug or will enrollment to those trials will helpful for that patient also? Thank you, sir.
So, actually a good question. So, we need to understand the basic difference between the pathophysiology of IgA nephropathy and other inflammatory glomerular disease versus FSGS, the full form of being focal segmental glomerulosclerosis. In adult, the focal segmental glomerulosclerosis is a morphological diagnosis. The underlying pathophysiological diagnosis is extremely heterogeneous. If almost all FSGS are caused due to genetic mutations. So FSGS widely is now classified as a podocytopathy. It's been seen most of the time the morphology comes normal. The pathologists label them as unsampled FSGS because FSGS is a focal disease. You might not pick them up in kidney biopsy. So they imply that it possibly be an FSGS because minimal change disease is not so common in the age you have described, first time presenting. So the disease is unsampled FSGS. Now the trend has changed to treat this kind of disease after seeing an electron microscopy. In electron microscopy, you see the effacement of the food processes of the podocytes, which were sine qua non for the minimal change disease that we described. We now understand that these are the diseases of the actin and the myosin filaments in the podocytes. The damage of the actin and myosin filaments, sometimes it's a single gene mutation, sometimes it's a multiple gene mutation, many times it's not understood. So FSGS does not really respond to the immunosuppressives like MMF and all these things as good as IgA nephropathy. But FSGS being treated with steroids, and if somebody is steroid resistant, of course rituximab, I understand the disease course of course very virulent. So there should be a pathological variant called as collapsing FSGS. One of the pathological variant of collapsing FSGS which can lead to CKD within 3 to 6 months after the diagnosis of the first time diagnosis of FSGS. If that is so, then the kidney disease which has progressed to CKD is due to the collapsing FSGS, and the most important thing is they have an extremely high chance of recurrence after transplantation also. That we need to discuss with the patient attendants and who is undergoing the transplant, that this disease is possibly going to recur after the transplant as well.
Sir, the main reason behind me asking this question was that the drugs which is RNA inhibitor that works on genetic level, and FSGS is also some sort of genetic disease.
No, that research has been not done. I hope there will be researches, but sparsentan, the DRR, they have seen the dual endothelin and angiotensin antagonist, they have shown to reduce the progression of disease in FSGS as well. There are trials with FSGS.
Thank you so much, sir.
Question, one more question. No questions? Thank you, Dr. Upal Singh Gupta. Thank you for your nice presentation.
Thank you, sir. Now I will request Dr.
Sir.
I will request Dr. Rajendra sir, CMO IC DSP, to felicitate our speaker and the moderators. I will ask sir to also felicitate our chairpersons. Sir. Now we are proceeding to next session, that is OHS paper. I would like to invite the chairpersons on the stage, Dr. Vinita Dwivedi ma'am, CMO IC Vilai Steel Plant, and Dr. Jitendra Nath Sharangi, CMO IC RINL Visakhapatnam.
We'll start the OHS session. The first topic in the list is by Dr. Madhavi from RINL, morbidity patterns in contract employees of RINL.
Good evening, everyone. My topic is morbidity pattern in contract employees of RINL. Contract employees play an important role in steel production. Aims and objectives: to evaluate the morbidity pattern in contract employees, to take specific measures for prevention and control of morbidity. Study design is a cross-sectional study. The sample size of 1830. Contract employees attended health checkup at OHS during the period of April 2025 to October 2025. Risk factors evaluated: hypertension, diabetes, vision impairment, abnormalities in audiogram, ECG and chest X-ray, smoking and alcohol habits, morbidity prevalence and causal factor analysis, and strategic plan for prevention and control. This is an annual checkup process. Online nominations sent through HR, and all the tests are done at OHS, and clinical evaluation by the doctors. If all the tests are normal, the contract employee is given fit. If abnormal reports, they were referred to either to ESI hospital or state government hospital or insurance hospital, and again reviewed. If normal with treatment, they are given fitness. If abnormal, they may be, as per the reports, they are given either temporarily unfit or unfit for hazardous operations. Morbidity assessment is done by the following way. Then age distribution, around 45 to 54 age group or above more than 90%. Morbidity profile: hypertension 10.4%, diabetes 11.5%, vision abnormalities 11.5%, and alcohol in 13%. Body mass index: 32% were overweight. Hypertension 42% we found to be of poor drug compliance. In diabetes, 34% were newly diagnosed after the checkup. Vision abnormalities, 54% are found to be of refractory error. Audio abnormalities, 4K notch in 54%. All the ECG abnormalities for patients were referred for 2D echo and cardiologist consultation. All the chest X-ray abnormal patients were done HRCT and referred to pulmonologist consultation and treatment. Smoking, 60% were smoking more than 5 cigarettes per day. Alcohol, 45% are taking alcohol once in a week. Coming to causal factors analysis, 43% of alcohol is said that they take alcohol to get proper sleep. Smoking, 42% said that they smoke to avoid sleep during working hours. Poor drug compliance for hypertensive, they said they don't have symptoms, they'll stop taking medication. In case of diabetes, 44% said that they have some financial issues to purchase the medicines and continue the medication. The challenges as concerned I found during this process are alcohol to relax the body, smoking to avoid sleep, fear to visit the hospital, shy to use spectacles, stopped medicines has no symptoms, hospital is far and visits are time taking, medicines are expensive. So results and discussion, 32% of study population are overweight, prevalence of alcoholism is 13%, 34% diabetics were newly diagnosed, 28% of hypertensives are newly diagnosed, poor drug compliance in 42% and 26% among hypertensives and diabetics respectively. Strategic plan, individual counselings, awareness sessions, group counselings and follow. Individual counselings we already started, and specifically we are covering the topics of for habits, drug compliance, doubts and stigmas for about treatments, and we are also discussing the free health facilities available nearby their stay. And coming to the future plans, we would like to take department-wise health education sessions, department-wise group counseling, specific group counseling for alcohol and smokers, review and follow. Health education, the plan is to cover the following topics: smoking and alcohol hazards, NCD control and stress management, occupational health and importance of PPE. Group counseling, importance of drug compliance, doctor's consultation and clear eyesight, importance of wearing spectacles for refractory errors, healthy food habits and PPE usage. Specific group counseling, tips to quit alcohol, tips to quit smoking, and case discussions for addicts of alcohol, about addicts of alcohols and smokers. Success stories by co-workers who already stopped smoking and alcohol. So finally, the inference is workers' health is determined by awareness, attitude and dedication of the worker, as well as a supervisor, contractor and engineer in charge. This is a teamwork. Thank you.
Can allow questions now for the question and answer session.
Madam, your new cases of diabetes and hypertension were too high, I think. So, before this health checkup, what was the interval between the previous health checkup? Because the new onset diabetes were 32% and hypertension was 28%.
Yes, sir. Actually, previous statistics was not very clear because previously the health checkups were done by the outside agency. With the ministry guidelines, we started doing health checkups for the contract employees from last year only.
Okay. I think one thing is left, that dyslipidemia part. You can include that one also. That is a major comorbidity.
Sir, we have done the lipid profile, sir, but I have not included that in this study right now.
Any other questions?
Madam, I know you didn't include. I know you didn't include regular employees in this, but can you just give a fair idea, like how do they compare to the contract employees profile?
Comparing to regular employees, drug compliance is it's very poor in contract employees, sir. And there are some stigmas in refractory errors, and also here obesity is very less comparing to employees. Yes, ma'am.
Thank you, Dr. Madhavi.
Thank you.
The next presentation is going to be from क्या मुझे दिखता नहीं चश्मा without the specs.
Retrospective analysis of workplace injury to understand the need for behavioral intervention. Dr. Aismoc Johnson, Durgapur Steel Plant.
Good afternoon, all. In spite of several efforts, injuries are taking place in the different working zone. Respected chairperson and honorable judges, the subject of my study is retrospective analysis of workplace injury to understand the need for behavioral intervention. According to International Labour Organization, occupational injuries are among the most common health problems. It is estimated to be 4% of the GDP lost is due to occupational accidents. Different studies previously done shows that musculoskeletal injuries are common occurrences in the work setting. A systemic review and meta-analysis of previous studies revealed that the global incidence of occupational injuries was found to be 55% in iron and steel industries. Our aims and objectives of the study was to determine the incidence of different types of occupational injuries and the need for behavioral intervention. Data for different injury types were collected every month according to an ILO classification system that standardizes the information for occupational injuries. Analysis of last 3 years injury data was carried out. Incidence rate and severity rates were calculated as per ILO guidelines. Only new injury cases were included in the study, and the result shows abrasions or cuts and foreign body injuries were consistent in the study period, received treatment on OPD basis and did not require hospitalization. Reduction in admission from 1.02% to 1.21% to 1.02% is also been observed during the study. The most injured body parts in the present study were upper extremities, and this finding is consistent with several international studies done in iron and steel industries. For instance, studies from Brazil, Iran, Ethiopia, Tanzania, and other parts of India. Strict compliance with wearing protective glasses is a vital requirement to prevent eye-related injuries. A significant majority of eye injuries are entirely preventable simply by using the correct protective equipment for a given task. Reduction in musculoskeletal injuries was observed during the study, including reduction in fracture cases. The number of contact burns has been reduced over the years. The positive trend is attributed to the improvement in public awareness and safety regulations. However, burn injuries remain a significant health problem in certain areas of the plant. Incidence rates are calculated as the number of new cases of injury during the calendar year, and severity rates measures the number of lost work days per number of labor hours worked. These two parameters provide comprehensive and timely information for prevention purposes. These are the top 5 injury-prone areas of our plan, as you can see from the pie chart. Several areas prone to injury, particularly those involving common, less severe incidents, consistently show lower hospital admission rates. This phenomena is largely due to the nature of the injuries, which can be managed on outpatient basis, and behavioral intervention can reduce the incidence rate. An article was written to sensitize the different issues towards achieving the goal of making bloodless steel. A safety initiative was launched by Durgapur Steel Plant called Jagriti. It has got several verticals to look after improvement at different areas. To summarize, a high rate of injuries was observed during the general shift, and this is likely due to the combination of more number of workers working in general shift and they are involved in high-risk tasks. The abrasions and foreign body eye injuries are accelerated in the study period, mostly minor in nature. Over the last 3 years, the overall decrease in employee admission for workplace injuries has been observed. However, there is a parallel increase in recovery time for some of these injuries. To conclude, individual and collective behaviors are crucial for safer decision makings. This collective behavior is a cornerstone of effective community safety and accident prevention. Along with other safety measures, human behavior ought to be given utmost importance. Implementing safety best practices both on and off the job is essential for overall well-being. By fostering a strong safety culture, employees can protect themselves, their families, and the community. This holistic approach ensures the safety-conscious habits are maintained at work, at home, and while traveling. Thank you, and our motto is production of bloodless steel.
The house is now open for the question and answer session.
Sir, any difference between contractual worker and permanent employee? Difference between?
Sir, we have included both contract and permanent workers in this study and total number. So exactly we did not done that discussion in our study. In future prospective studies we can include also that.
ये करना चाहिए सर, क्योंकि कॉन्ट्रैक्चुअल वर्कर बार बार बदलते हैं तो इंजरी, नंबर ऑफ इंजरीज सबसे ज़्यादा कॉमन उन्हीं में होगी, क्योंकि वो बिल्कुल उसके लिए कस्टम नहीं होते. हाँ सर, परमानेंट एम्प्लॉइज में उसी जगह वही काम करते हैं तो इंजरी कम होती.
हाँ, actually we have done a retrospective study, that's why we couldn't exactly include the separate incidents.
Must be knowing how many people from different categories suffered injuries, like how many contractual workers, some estimate?
We had more number of contract workers are in DSP plan. So obviously the incidence will be high in.
High. That is what we are saying. Any other questions?
One more question we can allow.
Okay, thank you.
Thank you.
Pattern and prevention of accidents associated with crane and heavy equipment in sale, ISP. Dr. Gaurav Diogaria from Bokaro Steel, no, from ISP, Burnpur.
Respected chairpersons, judges and delegates. Good evening to all of you. Myself Dr. Gaurav Deogharia, and my topic is on pattern and prevention of accidents associated with crane and heavy equipment in SAIL ISP. Crane and heavy equipment operations involve tasks such as material handling, lifting and transportation of heavy loads. However, they also pose significant safety risks, often leading to severe accidents. The objective of my study was to analyze the pattern and the associated risk factors of accidents, to outline measures to prevent such accidents, and to analyze the outcome of our intervention. Retrospective study was conducted at SAIL ISP, the duration of which was January 2023 to December 2025. Workers were divided into two groups, A, the permanent workers, and B, the contractual workers. Data was analyzed using software SPSS version 22. Coming to the inclusion criteria, types of equipment such as overhead cranes, mobile cranes, tower cranes, and heavy mobile equipment such as loaders, slab carriers, and forklifts were included in this study. Accidents directly involving crane and heavy equipment operations such as load dropping, crane collision, equipment derailment, and structural failure were also included. Accidents with adequate data for analysis such as incident report, witness report, and CCTV records were also included. Coming to the exclusion criteria, accidents unrelated to crane and heavy equipment operations such as slips, trips, and falls were excluded, and also accidents which occurred outside the operational steel plant were excluded from this study. Some of the most frequent crane and heavy equipment injuries were head injuries, bony injuries, lacerations, amputations, spinal cord injuries, and crush injuries. Here are some of the ergonomic factors which predispose to these sort of accidents. To name a few, low back pain, cervical strain, and hand-arm vibration syndrome. Coming to the cause of accidents, the first and the foremost important cause which resulted in these sort of accidents was found to be operator error. Here are some of the illustrations which goes on to show how an operator error can result in these sort of accidents. The first pic shows improper load, the second one shows no outriggers being deployed, and the third one shows incorrect outrigger span. The second cause after operator error was communication failure. The third one was crane mechanical failure. As can be seen here, irregular grooves and unguarded chain drive can result in these sort of accidents by causing load dropping and equipment derailment. And the fourth one was poor visibility. Coming to the injuries according to cause, operator error accounted for 72% of the cases, followed by communication failure 12%, crane mechanical failure 10%, and poor visibility 6%. Here's the time-wise distribution of accidents. These sort of accidents were found to be most common between 8 a.m. to 12 p.m. and again between 3 p.m. to 6 p.m. Coming to the month-wise distribution of accidents, these sort of accidents were found to be more common between the months of May to August. Here are some of the risk factors which resulted in these sort of accidents. To name a few, the first one was human factor, where lack of PPE and manual error resulted in these accidents. Environmental factors such as wind, temperature, and visibility. Methodical factors such as violation of SOP, and materialistic factors such as worn out wire ropes and cracked hooks led to these accidents. Coming to recommendation and action taken, first aid training program was conducted at the shop floor, audiometry tests were done, randomized breath analyzer tests were conducted, vision tests were done, chronic diseases were managed, and job rotation was put into place. Some of the engineering measures which were put into place were in association with ergonomic risks and their control measures. Camera and monitor placement to prevent neck strain, air suspension seats to prevent low back pain, and anti-vibration gloves to prevent hand-arm vibration syndrome. PPE promotion was done, work rest cycles were incorporated, and road safety awareness program were conducted in collaboration with safety department. Here is the analysis of accidents. As can be clearly seen here, these sort of accidents were more common among the contractual group of workers as compared to the regular group of workers. However, the number of accidents kept on decreasing from the year 2023 to the year 2025. There was a significant decrease in the IOW reported trend. One of the most intriguing features of our study was that there was quite a significant reduction in the number of near-miss incident cases when it came to the year 2025 as compared to 2023 and 2025. My take-home message would be, PPE is non-negotiable, work as a team, take proper rest, don't take periodic health checkups lightly, manage fatigue and distress, protect yourself and your team. Here are some of my references. My acknowledgements. Thank you.
Thank you for the presentation. Now the house is open.
Doctor, actually in plant safety, are you getting my point?
Yes, sir. Yes, sir.
Usually in plant safety, the near miss and the accident case,
Yes, sir.
they have a just opposite relation. To reduce your accident and fatality, the near miss should rise.
Reported.
And in your study, both are declined. So how it is possible?
So the near-miss incidents decline means that's a positive thing, sir, for the plant. Means the incidents
No,
were
the
about to
concept
happen
is
that
this,
there was a
The concept
decrease.
is that
Yes, sir.
if you detect your near miss cases,
Yes, sir.
then only maximize your near miss cases, then only you can prevent your fatality.
Yes, sir.
That means you are detecting the future accident.
Yes, sir.
Like
Sure,
the
sure.
accident.
Sure,
So
sure.
near miss should not decline to increase the safety.
There was a reduction in the number of near-miss cases, sir, and there was quite a significant reduction in the number of injury cases too, sir, as evident from my study. Yes, sir.
You said that there was an increase in incidents from May to August.
Yes, sir.
What could be the possible reasons?
So thank you for this question. Sir, there was the first and the foremost important reason is high ambient temperature, sir. What high ambient temperature does is that it heats the hydraulic system and also softens the rubber tires, which can lead to sudden blowouts, increasing the susceptibility to accidents. Also, sir, the metal parts of the equipments, they just swell up in those sort of environmental conditions, which can lead to misalignment and also result in accidents. And the third one is, sir, that during that point in time, there is high wind in those months, which can lead to load swing and load sway, which results in those sort of accidents.
Thank you. Thank you. We go to the next presentation.
Thank you, sir. Thank you, sir.
Prevalence of foot problems associated with wearing safety footwear in Rourkela Steel Plant. Dr. Basudev Jena.
Good afternoon, everyone. Respected chairpersons, respected head of medical, my seniors and my colleagues. My topic deals with the prevalence of foot problems associated with safety shoes done as a cross-sectional study at the Occupational Health Center of Rourkela Steel Plant. A steel toe boot, also known as safety shoe or safety boot, protects the foot from falling objects or compression. Specialized footwear has been developed to enhance the safety and performance while an individual is involved in workplace activities. According to Occupational Safety and Health Administration (OSHA), protective footwear is included in the mandatory personal protective equipment section. The common components of various shoe types which the American Academy of Orthopedic Surgeons has provided includes toe box, sole, heel, etc. OSHA defines this type of protective shoe wear as having impact-resistant toes and heat-resistant soles, the metal insoles to protect against puncture wounds. Safety shoes may also be designed to be electrically non-conductive. Shoes can be made non-slippery for areas with water, oil, etc. Safety shoes can cause discomfort due to their weight, poor ventilation, improper use, and lack of awareness about ergonomics. Prolonged wearing of safety footwear plays a vital role in the progression of foot and toe problems such as plantar fasciitis, tendinitis, toenail fungus, etc. Aims and objectives of this study are study of prevalence of foot problems associated with safety shoes and recommendations for remedial measures. The place of this study is the Occupational Health Service Center of Rourkela Steel Plant. Study was done between 1st January to 31st of August 2025. It involved 240 employees, 180 non-executives and 60 executives. This study focused on both executives and non-executives from age 18 to 60 years of age. However, those having health concerns like diabetes, any ankle or below knee fracture, etc. have been excluded. A self-made questionnaire was designed and was validated after ethical committee approval. 240 employees of RSP working in different departments were invited to participate in the study through Google Forms. It was a cross-sectional observational study in which informed consent was taken from each participant and given brief introduction about the research, followed by providing the questionnaire to be filled. General foot examination and ortho consultation was done for all employees. This is the questionnaire. Descriptive analysis of the data collected was done using Microsoft Office Excel. The responses were converted into percentage and represented in pie chart form. Results and discussion as follows. Among non-executives, 171, that is about 95%, wear safety shoe for more than 8 hours. Only 9, that is about 5%, wear for less than 8 hours. Among executives, all 60 wear safety shoe for more than 8 hours. These are the chief complaints among executives and non-executives after wearing safety shoes, which include pain, tingling sensation, sweating, etc. As you can see, pain is seen is the most in most number of non-executives, that is 36.66%, while heaviness and sweating is seen in the most number of executives, 33.33%. These are the common diseases associated among non-executives and executives after wearing safety shoes, which include arthritis, tendinitis, foot corn, etc. 60% non-executives and 65% executives said that their safety shoe is comfortable for them. 99% non-executives and all executives change their safety shoe yearly as per this study. Only 1% non-executives did not change their safety shoe. These are the conclusion based on this study. On an average, more than 8 hours safety shoe wearing time in executive is about 100% and in non-executive is about 95%. Pain is the chief complaint in non-executives. Sweating and heaviness are the chief complaints in executives. Arthritis is the most common disease associated in non-executives, while hemato, corn, nail fungus and heel spur are the most common disease associated among executives. These are the recommendations. As every foot has a unique anthropometric design, flexibly designed safety shoes must be thought of instead of a fixed design. Shoe weight is one of the major factors for non-usage. Instead of a heavy steel toe cap in existing safety shoes, a new lightweight and harder material is to be thought of in the future. Inside ventilation of safety shoes must be improved as most employees work for 8 hours in hot and humid environment. Well-spaced toe caps can be helpful in this case. Mass awareness for wearing safety shoes with gel pad or memory foam needs to be initiated at all shops for better safety and comfort. Thank you.
Thank you. Thank you for your presentation. Now the house is open for question and answer session. I just want to know one thing. You said 240 people you have seen those wearing shoes. But I think when you go to in a plant anywhere, you see 50% of the people do not wear any shoes. What about your recommendation for that? See, and when you highlight that people have issues of this tendinitis and this, then they will say that we don't want to wear the shoes. Many of the people, they don't oblige with the safety shoes wearing norms.
Sir, safety shoes as such should be used by the employees for their own safety while working, and all these complaints and those diseases that are associated with them that may get aggravated by them, they can be allayed by taking proper measures such as changing the safety shoe every year, and if someone's shoe is not someone's foot is not fitting the shoe, then they can take orthopedic consultation. And but just for avoiding these complaints, I think they should not miss out on wearing safety shoes.
Yes, please.
Hello. How you attributed this foot problems only due to safety shoes? It could be due to proper not following the proper ergonomics. It could be due to the other shoes also, what he is wearing in his home or he is while during his normal walking. How you attributed that it is due to only that safety shoes? What was the check?
Actually, sir, safety shoes they are not made according to each and every other person. They are standardized. They come in one size for every employees. Because
Thank you for your presentation. Well done. But then this should be seen how 100% utilization of the shoes or usage of the shoes should be done inside the plant for protection, because many people in our organization, I see during a month of around probably July August, where the Ayappa Swami festival comes. For 1 month almost they don't wear anything. They come in empty without any shoes or anything to the plant with a black dress. And that's again sentimental, and they do it. But then yes, it must be done, and we should ensure that they come with the safety shoes to the plant premises. Thank you. The next presentation is going to be
A study on prevalence of musculoskeletal disorders among crane operators of a steel plant. Dr. Sonak Ghosh, Bhilai Steel Plant.
पेज अप डाउन होगा ना साइड में होगा Respected Chairperson, Honorable dignitaries and dear colleagues, I am Dr. Sonak Ghosh from Bhilai Steel Plant, and I shall be presenting our study on prevalence of musculoskeletal disorders among the crane operators of Bhilai Steel Plant. By definition, musculoskeletal disorders or MSDs are injuries and disorders that affect the body movement or the musculoskeletal system, that is muscle, tendons, ligaments, discs, joints, etc. Globally, they pose a significant health risk because not only they causes pain and disability, but also they causes reduced productivity, prolonged absenteeism, and chronic workforce attrition. Crane operation involves prolonged sitting, repetitive vibration exposure, constant postures, and therefore they are at increased risk of developing MSD. But in India, in a large steel plant setting, limited data is available among specific to crane operators, which forms the basis of our study. Among the international literatures that are available among the heavy equipment operator or the crane operators, including Nordic musculoskeletal questionnaire, there is significant prevalence of musculoskeletal disorder with lower back being the most common prevalent region. But in case of Bhilai Steel Plant, there is lack of significant data which prevents us from developing ergonomic intervention or developing any kind of ergonomic prevention data. So it forms the basis of our study. So aim of our study was to determine the prevalence of the musculoskeletal disorders among the crane operators of Bhilai Steel Plant. Objectives were to estimate overall MSD prevalence in 12 months, 7 days and work limiting scenario, describing region-wise distribution of MSDs, and assess the association of age, work experience or body weight. So we did a cross-sectional observational study among the crane operators of Bhilai Steel Plant. Initially, 120 crane operators were chosen. Among them, all of them were of 26 to 50 years of age and having minimum 5 years of work experience. Among them, 7 were reassigned to other jobs due to previous medical condition, 5 were long absentee, and 4 were having symptoms due to previous injury while committing to work, and that is not work related. They were excluded and final sample size became 104. We provided them with modified Nordic musculoskeletal questionnaire, which is shown here. Body is divided into 9 anatomical regions, and that data was collected from 12 months, 7 days and work limiting scenario. Responses were binary in nature, that is yes or no type. Informed verbal consent was taken from the candidate, and standard SPSS software was used for data analysis. Outcome was defined using standard epidemiological applications into 12-month MSD, 7 days MSD and work limiting MSD type. So result wise, overall there is 26.9% prevalence in the 12-month MSD scenario. Body region wise distribution had lower back accounting for almost 2/3 of the cases. In both 7 days recall period and 12-month recall period, lower back emerged as the most common site for development of pain, followed by neck and upper back. In work limiting MSD type, spinal involvement became the most common site of involvement, emphasizing their ergonomic and epidemiological significance. Interestingly, young and less experienced population produced more number of absolute complaints. Body region wise distribution also showed the similar pattern. But when we did epidemiological association test with logistic regression and forest plot analysis, we found out age and experience having significant association with development of MSD with higher MSD per individual. However, body weight did not show any significant association. This difference between raw count and MSD per person is important because it helps us to declutter the inflated body region, multi-site body region complaints, and helps us to show the true prevalence, true disease burden. By this scenario, we found out that although younger and less experienced worker had greater number of complaints, but older and more experienced worker had significant higher burden per individual, which showed cumulative occupational exposure, with lower back being the most common prevalent region. Our study is in line with international studies that are available among the global population and also the crane operators, especially in detecting the lower back being the most common prevalent region. Overall prevalence is, however, lower than the global population, but this area is somewhat cloudy and therefore leaves much room for improvement. By this study, we can recommend for cabin ergonomics improvement, especially in case of lumbar support and optimal control panel, prioritizing lower back posture education and frequent microback strategy, periodic health surveillance and early referral pathways. So in summary, almost 1/4 of the BSP crane operators have MSD symptoms. It may be lower than the global estimate, but still it is consistent, with lower back being the most common prevalent region. Age and work experience has meaningful association with development of MSD, which requires targeted ergonomic intervention and surveillance programs. Thank you.
Now the house is open for question and answer session. Any questions? Okay, if no questions are there, madam, you want to ask?
No, I don't want to ask. Okay, okay, thank you. Now the last of the lot is the efficacy of silicone insoles for alleviating lower body musculoskeletal complaints, a prospective workplace ergonomics intervention study, Dr. Soumya Smruti Parida, Tata Steel Plant. Everybody is talking about ergonomics nowadays.
Respected chairpersons, esteemed judges, my seniors and my colleagues, very good evening. So earlier we have observed there has been an increasing trend in lower musculoskeletal complaint among industrial workers. And in a retrospective analysis, we have also found majority, that is 20% of workers presented to OSC with lower musculoskeletal issues. So these complaints are mainly about pain in feet, toe, sole, knee, ankle, thigh muscle, hip muscle and calf muscle. Many of these workers, when referred to an orthopedician, there has been a consistent recommendation of use of silicone gel insoles. So here is a graphical representation of safety shoe. Safety shoe is a vital part of our industrial personal protective equipment. However, they are heavier, stiffer and poorly cushioned. The rigid outsole and limited cushioning of the insole reduces the shock absorption, allowing the heel strike up to twice of the body weight, thereby transmitting the stress to the lower limb, particularly on hard industrial flooring. So what is the health impact on workers? During 8 to 9 hours of the shift duty, workers have been exposed to repetitive cumulative biomechanical loading. Each step generates a substantial impact forces, and over 1,000 of steps per shift per day leads to micro trauma of the plantar soft tissues, ligaments, joints and cartilage. Prolonged standing reduces the dynamic muscle pump activity, and hard industrial flooring further amplifies the transmission. Thereby, overall, all this combination contributes to persistent plantar pain, altered hip ankle biomechanics, increased knee joint stress and eventually compensatory postural adaptation. So, there has been various researches on how safety shoes affect our lower musculoskeletal health of our industrial population, and researches has already shown silicone gel insoles are effective in normal footwear and also athletic footwear, but limited researches has done on how a silicone gel insoles are effective in industrial safety shoes. As for the biomechanical context I have already mentioned, our aim is to study the effectiveness of silicone insole, and our specific objectives were to assess the pain distribution and to evaluate changes of pain severity over time. So this is a prospective study conducted over a period of 6 months. We have included male shop floor employees aged 25 to 45 years who have been regularly using safety shoes and with a history of lower limb discomfort, and the exclusion criteria has already mentioned here. To assess the lower limb discomfort, we have used a modified Nordic musculoskeletal questionnaire. This is the questionnaire we have used in this study. In our intervention detail, we have used a dual gel silicone insole where the uppermost layer is the anti-sweat fabric layer for moisture control and comfort, and the silicone gel core is for pressure distribution and microshock absorption. As you can see in the graphical representation of how a gel silicone insole works, that is before and after images, the plantar pressure distribution improved with an increase in contact area and reducing the maximum pressure bilaterally. Coming to results, we have included 195 shop floor employees, out of which 48% are contract employees and 26% of each are subsidiary and payroll employees. Maximum participants reported pain in multiple anatomical regions, and feet, toe, sole is the highest reported pain area among our participants, followed by knee and ankle, and fewer proportion of the participants also reported pain in thigh muscle, hip muscle and calf muscle. We have also included BMI of the participant. So here 63% are obese, 19% are overweight and 18% are normal BMI. Literature has also shown that higher BMI increases load on weight bearing structure and plantar structures. That's why amplifying the lower musculoskeletal issues even more. In statistical analysis, normality test conducted using Kolmogorov, Spinum and Shapiro-Wilk test, data was non-normally distributed. That's why Friedman test conducted in baseline 3-month and 6-month phase. And post-hoc analysis also showed the, in Wilkinson signed rank test also shown the significance. In a percentage pattern, functional improvement was increased by improving the walking ability, so increased from 86.6% to 89.2% in stage 3. The observed pain distribution aligns with our study objective of lower limb musculoskeletal burden associated with prolonged use of safety footwear, and silicone gel insole improve the pressure distribution by increasing the contact area and reducing the maximum pressure bilaterally. So the improved shock absorption likely reduce the heel strike dominance, which is a key contributor factor of the foot pain, and the altered plantar pressure likely influence the gait mechanics, thereby the stress may be transmitted to the lower limb. That's why participant has reported pain in multiple anatomical regions. Coming to conclusion, prolonged standing and walking in non-ergonomic safety footwear can affect the lower limb musculoskeletal health of our industrial workers, and silicone gel insoles offer a cost-effective, non-invasive adjunct to improve the comfort and functional tolerance. In my limitation, female participants are not included. The study relied primarily on self-reported data, and objective assessments were also not included in this study. So my take-home message is ergonomic modification as small as a silicone gel insole can significantly improve the gait mechanics and reduce the heel impact and enhance both mobility and functional performance among our industrial workers. These are my references. Thank you.
Madam, why you not included female employee?
Good evening, sir. Thank you for the question. Sir, the male insoles are available in fit to trim size. That is, one insole if we have ordered, then we can fit and trim it and fit into the male size. But female insoles require a specific order for each female. We have required another insole, and if we have 50 female insole we have included, then we have it would have ordered 50 different insole. That's why for logistical constraint we have.
No, that is not required. You can have an insole and you can cut it and trim it as per your requirement, because I have done it for myself.
Yes, ma'am.
So females and males में कोई difference नहीं है. They ask the length of the foot and you can trim it.
Madam,
The customization has to be done
yes, ma'am,
ourselves.
I understand, ma'am. But the insole we have used, that is dual gel silicone insole, that has two different sizes, ma'am. The normal insole had various size. You can fit and trim it too. But we have used a dual gel silicone insole. That had different, madam. That had different, female has different, as per their size, they have different insoles. That's why we have removed the female participants.
So customization had to be done for females. So
for the
Rourkela Steel Plant has an answer for their safety shoes by Tata. I think, I mean, the answer was done by the Tata to Rourkela steel plant. This is what I felt. Any other question, please?
Dr. Soumya,
Yes, sir.
have you differentiated the effect of this silicon in sole from other ergonomic intervention?
Sir, I could not get it. Can you please repeat, sir?
Other ergonomic intervention you have made apart from the silicon in sole?
No, sir. We have designed this study. Why? Sir, because we have seen a consistent report of recommendation of silicon gel insole by orthopedics after excluding all our factors. That's why we designed this study, because there has been no studies at all in Indian setting by incorporating a silicon gel insole into industrial footwear.
Okay.
Okay, thank you. I'm sorry to have left out Bokaro steel plant. So we have one more paper by dermal effects of coal tar exposure in industrial workers at Bokaro steel plant by Dr. Rajneesh Kumar.
Now, good evening, everyone. Respected chairperson, sir, esteemed judges, respected seniors, and my dear colleagues. My presentation today highlights the dermal effects of coal tar exposure in industrial workers at Bokaro Steel Plant. Now, coal tar is one of the most important byproducts obtained during destructive distillation of coal in any integrated steel plant. Now, this process involves heating of coal in coke oven batteries to a very high temperature of over 2000 degrees Fahrenheit in the absence of oxygen. Now, this heating causes carbonization of coal, leading to formation of coke, a very important raw material to be used in blast furnaces for reduction of iron ore. And there are liberation of certain organic compounds and gases. Now, these compounds, on cooling, results in formation of a highly viscous material called crude coal tar, which settles in the decanter section of the plant. This is first section. There's another section called tar pump house, which pumps this crude coal tar from the decanter section to a precipitator section followed by tar distillation plant, where on distillation of this crude coal tar results in formation of certain compounds like toluene, benzene, naphthalene, phenol, sulfate, certain byproducts that were previously used as dyes in cosmetics, including lipsticks and nail paints. And a final byproduct called coal tar pitch, which is used for making roadways and highways. Now, during periodical health checkups at our center, we observed instances of skin diseases among employees exposed to coal tar in various sections of coke oven. So we decided to evaluate this issue further. We had our aim to determine the prevalence rate of skin diseases among employees exposed to coal tar in various sections of coke oven. We wanted to determine the prevalent kinds of skin diseases in these employees, and had our aim to assess if there was any relationship between duration of exposure to coal tar and occurrence of skin diseases. So, a study was conducted. The study was conducted between October 2024 to September 2025. The total sample size was 146, but after applying the exclusion criteria, the sample size got reduced to 134, out of which 113 were employees who were exposed to coal tar, while 21 were employees who were posted in office section of the plant and had no exposure to coal tar at all. Now, those with pre-existing skin disease, those with history of systemic illnesses affecting the skin were ruled out from the study, excluded from the study. The diagnosis was based on history, clinical examination, and skin consultation. Now, coming on to the results. Now, this slide shows the prevalence rate of skin diseases among employees exposed to coal tar in various sections of coke oven. The overall prevalence rate was 21.2%. Now, this is quite high. It means 1 in every 5 employees suffered from skin disease due to exposure to coal tar. The maximum prevalence rate was observed in tar distillation plant followed by tar decanter section, probably because here the employees were directly exposed to coal tar, while those posted in tar pump house and precipitator section had lesser prevalence, as they were indirectly exposed to coal tar in the form of coal tar vapors. Now, none of the employees posted in office section suffered from skin disease, indicating that yes, coal tar is a significant risk factor for development of skin diseases. Now, this slide shows the pattern of skin lesions due to exposure to coal tar in decreasing order of prevalence. Now, the contact dermatitis was the most prevalent kind of skin lesion due to exposure to coal tar, while warts and skin atrophy were the least. Now, here the 29.2 plus 20.8, it means around 50% of the employees who had skin lesions due to exposure to coal tar either had contact dermatitis or folliculitis. Now, hyperkeratosis and melanosis, they were equally distributed at 12.5% each. Now, this slide shows the timeline of appearance of coal tar related skin lesions. Now, here we find that contact dermatitis, folliculitis, and acneiform eruptions, they usually occurred within first 5 years of exposure to coal tar, while hyperkeratosis and melanosis, they usually occurred after 5 years, while warts and skin atrophy, they occurred after prolonged exposure for over 10 years. Now, notably, around 60% of the employees who developed skin lesions due to exposure to coal tar developed their lesions within first 5 years of exposure. Now, here are some of the images of our employees who suffered from skin lesions due to exposure to coal tar. This is contact dermatitis, left hand. This is folliculitis, right lower limb, pre-tibial region. Acneiform eruptions over face. Hyperkeratosis, right hand thinner region. Melanosis over neck and chest wall. And warts over right hand, a pre-malignant lesion. So, ladies and gentlemen, I would like to conclude by stating that coal tar is a significant risk factor for development of skin diseases. Direct exposure increases the risk. The contact dermatitis and folliculitis are the most prevalent kind of skin lesions due to exposure to coal tar, and duration of exposure correlates with the type of skin lesions. Now, since coal tar related skin disorders shows direct correlation with the proximity and duration of exposure, there needs to be some concrete measures to decrease the risk, and hence the recommendations are: the use of PPE kits should be made mandatory. They should be strictly enforced. Engine controls, there should be proper ventilation system and tar extraction system at the workplace. Now, administrative controls, job rotation should be in place. Periodical health checkups should be done at regular intervals, and health education programs should be organized at regular intervals in order to educate the employees regarding the hazardous effect of coal tar and their safe handling practices. Thank you. Any questions?
Good evening. Myself, Dr. Pooja Syal. I wanted to know, like even we come across a lot of patients with skin manifestations working in the Coke 1. How do you attribute it to coal tar and not any other raw material?
Thanks, madam, for your question. But the answer is very simple. This is a cross-section study, and cross-section study, they never determine, they never establish causality. The causality is established by case control studies, cohort studies, RCTs most important, and meta-analysis. So this cross-section studies, these are called prevalence studies, and they are used for making hypotheses, like null hypothesis and alternate hypothesis. Null hypothesis means there is no relation between two variables. And if there is a relation, it is only by chance. Now we have to reject this null hypothesis in favor of alternate hypothesis. And so for this, other studies like cohort studies, case control, and RCTs has to be done.
Thank you.
Myself, Dr. Ram Chandra Chauhan from ISP. Also, the coal tar, the coal products contains many carcinogens.
Yeah.
So your study doesn't show any malignancy.
Yes, I got your point.
Is it by chance or?
No, it may be by chance, but there were cases of warts, and warts are pre-malignant. HPV warts that caused by virus, they are not pre-malignant, but here these are pre-malignant. Why? The coal tar contains this polycyclic aromatic hydrocarbons, and they are highly lipophilic. They easily penetrate the skin. They are metabolized by P cytochrome 450, reactive metabolites are produced and they cause mutations.
But has that been established yet? I think it has not been established. That
No,
it
this is
causes cancer.
pathophysiology. This is established.
No.
Pathophysiology is established.
No, that causes cancer has not been established. Till now, the research is going on.
The search is going on, but at least they are causing warts, which is pre-malignant lesion. Afterwards, it will convert to malignant lesion. Malignant lesion.
The cause has not been established.
This is. I already told that cross-section study they do not establish cause.
Yeah, that's some time tell. It is associated, but the cause is not established till date.
We know the pathophysiology, but cause has to be established by cohort studies and other studies.
Exactly.
Has one last question. In fact, has the urine benzoyl estimation of these patients done?
No, sir. No.
You have not done.
No, sir.
You have said that that these patients were followed up for a period of.
Sir, these patients were not followed up. This is a cross-section study. This is like photo snap. The information that we have got here, these are retrospective informations. These are not retrospective observations. Retrospective observation in 2015, then 16, then 17, then it would have been retrospective cohort study.
Okay. Now, I think we have completed all the presentations.
It is a cross-sectional study in many incidences. Okay. Okay. That was a good presentation. I think it needs a good follow-up too.
Yeah. We will be conducting
yes,
courses.
you can do a study, a cohort study
Yeah,
or
we
whatever
will-
you want,
yeah, we
so
are
that we come
scientific.
out with conclusion
Yeah.
that whether it is due to coal tar or any other causative effect.
Okay.
Okay. Thank you so much.
Okay. Thank you, ma'am.
Thank you, our chairpersons. I would like to invite Dr. Rajaranjan sir to felicitate our chairpersons. Thank you, sir. Thank you, ma'am. Now our last session. Topic is robotic surgery in urology and uro-oncology, and the speaker is Dr. Tarun Jindal, Senior Consultant, Uro-Oncology and Robotic Surgery in Apollo Hospital. I'd like to invite sir on the stage, and I would also like to invite the chairpersons, Dr. Binita Singh, GMMS, Tata Steel Private Limited, and Dr. Jayanta Kumar Acharya, CMOIC, Rourkela Steel Plant.
Thank you so much. Respected dignitaries on and off the stage. It gives me immense pleasure to be in front of you and sharing the story of the evolution of surgery and how the advent of robotic surgery has made its mark and how it has dramatically changed the management of urological cancers and general cancers per se. So we all started our training as surgeons by doing open surgeries, and my professors used to claim that the bigger the surgeon you are, the bigger the incision you give on the patient. But we as students and we as people who were in the wards and giving rounds and talking to the patients more closely, we always felt that yes, these surgeries were required, but they were very morbid surgeries. The patients were in the hospital for weeks together, if not months. These were very ghastly surgeries and patients required multiple blood transfusions. The morbidities were very high. The recovery times taken by the patients were months together, and a few patients could ever receive a functional status after months from these kind of ghastly surgeries. This is another example of a large retroperitoneal tumor, and you can see we have to give a post-mortem incision extending from the xiphisternum to the suprapubic area, and these surgeries were done by these particular methods. But we as surgeons were not very happy. We thought that, is there a way out by which we can actually increase the outcomes or improve the outcomes of our patients? Then we thought that God has been specifically kind to urologists, and it has given us certain organs which are actually accessible by the natural orifices. So the idea of doing a transurethral surgery came from the endoscopic era, and we started developing equipments by the virtue of which we were able to do transurethral resections of prostates. And we were very happy, and this happened just in the last 50 years. The patients who were in the hospitals for months together now were getting discharged within 48 hours. The amount of blood loss was much lesser. There was no practically any pain. So we thought that, okay, we have sorted the benign prostates. What about kidney stones or ureteric stones? We again toyed up with the ideas, developed our armamentarium, and developed certain scopes by the virtue of which we were able to get inside the kidneys, and these are the stones which are being tackled without any incisions. So these are like endoscopic managements of the kidney stones and the ureteric stones. So we thought that, okay, prostate is sorted, the stones are sorted. What about the urological cancers? Can we do something about it? And urological malignancies were extremely morbid surgeries, prolonged surgeries. We needed to take out multiple organs. So we thought, let's do something better in the field of urological malignancies. And what breakthrough we had in the last 20 years was the advent of laparoscopic surgeries in this particular genre. So what advantages laparoscopy gave us were that the patients were having now less amount of pain. The hospital stays dramatically came down. There were small scars, there was less amount of infections and less bleeding. The patients were recovering faster. But again, the handicap of a laparoscopic surgery was that the kind of instruments that we were using were good enough for a gallbladder, they were good enough for a hernia, but for urological malignancies like bladder, kidney, penile cancers, these instruments these are like straight instruments, so you cannot actually go into the depths of pelvis where the prostate is seated, or you cannot very comfortably reach the kidney, which is below the diaphragm, covered by the rib cage, covered by the spleen on the left side, liver on the right side, gallbladder. So there were a lot of practical implications. So this particular handicap of laparoscopic surgery led to the advent of the robotic surgeries development in the last 15 to 20 years. Now the advantage of robot was immense, but what is a robot? So we should not have that notion that a robot is an autonomic machine. It's like anybody who's playing a video game on his phone. So whatever you are basically doing or whatever buttons you are pressing, that is being replicated by the robot. So it's not an autonomic machine. It's like driving your car. So how well you drive your car will determine whether you'll reach from point A to point B safely. So this concept is called master-slave system. So you are the master, the machine is your slave. So you whatever direct the machine to do, the machine will do exactly the same. So you are operating on a patient without cutting open the patient. How are we able to do this? This is because of the virtue of advanced instruments. These are the 3D telescopes. So like God has given us two eyes, by the virtue of which we are able to have a 3D vision. We know the depth perception is there because of the human eye. So the machine was very smart enough. So the engineers basically copied the human eye. They made two lenses, and whatever the image was being generated, it went on like a 3D image, like the way the brain processes the images from our two separate eyes. And we sit on this particular console. The left image is here, the right image is here, and our brain does the fusion. And this leads to us seeing a 3D picture, which was never possible before the advent of the robotic system. And this is what actually made the difference. This is a prostatic surgery in motion. And what you see, these vessels, these small vessels are a few microns in size. That is almost the size of your hair. And this is how magnified they look. And this, what advantage which I get as an oncosurgeon is that I know what tissue is normal and what tissue is abnormal. I can very precisely save the tissue which I want to save, and I very precisely can take the tumor out without damaging the adjacent structures. So that gave me an edge over any other platform of surgery which was available before. And it was almost as if I had my hand inside the patient's body. Just imagine if I have to put two of my hands and 2 of my hands of my assistant. So 4 hands into a patient's abdomen means you need to have at least a 20 centimeter or a 25 centimeter incision. But what this company made is that they made instruments which were similar to the wrists of the humans, which is called the endo-wristed instruments. And the size of this instrument is 8 millimeters smaller than the pen which you are holding in your shirts. So these are very small instruments, and it is almost as immersive a surgery that a surgeon can do. It's as good a surgery as an open surgery is being done, but you need not cut open the patient at all. You just have small 8 millimeter instruments which do the job for you. And this is how the robotic OT actually looks. So the surgeon sits on a console which can be here, which can be a kilometer apart, or which can now, with the advent of telesurgery, can be continents apart. It does not matter where this console is. And the surgeon sits here. He is not even near the patient. So the entire control is done by the surgeon sitting here, and the entire machinery which he controls from here is positioned on the patient's body. And what do we have on the patient bedside is an assistant who can basically do suctioning, supply needles during surgery, and a scrub nurse. That's all that we need, who can change the instruments. This is the entire requirement or a paraphernalia required for an robotic OT setup. So this is my robotic journey. So I started my MS Masters in 2009. That was the time when India had only 2 robots. One was in Scotch, New Delhi, and the second was at AIIMS. We were still toying with the idea whether it is going to make any difference in the outcomes of our patients, but it actually did. So 2009, we were the first group who performed 25 chest surgeries by the virtue of robotic, and that was the first and the highest experience in the country. I was an assistant at that particular time. I was doing my masters. So my boss used to do, we used to assist, but we were the team who performed the largest numbers during that time. In 2013, I came back to Calcutta, and I basically was certified. So that time, it was very intensive. It was more difficult to get a robotic certification, even more difficult as compared to your licensing of driving which you get. So we had to sit for at least 4 examinations, hours of training, and then only the company used to certify us. But then God has been kind, and there was no looking back. So in 2019, our group was the first group which described robotic groin dissections in the patients of carcinoma in penis. And now this is the most commonly followed technique across the world, and we have been invited across the country to present this particular surgery and perform this surgery across various platforms. There were other first landmarks which we did during the last couple of years. And again, because of the gods being kind to us, we have been able to perform the highest numbers of robotic oncology cases in Eastern India. Now I'll come to the major surgeries that we do and what difference do the robotic platform make on the outcomes of this surgery. So this is robotic radical prostate, one of the most common surgeries that we perform. And these are the only cuts that we make on the body of the patient. This is how the robot is brought and the instruments are dipped in. And you can see the difference. This is the amount of magnification that I get during my surgery. This is a right-sided pelvic lymph node dissection. That's the external iliac artery. That's the external iliac vein, internal iliac vein. You can see the obturator nerve. You can even see the vasa vasorum. So I've just removed the nodes, and you can actually see the vasa vasorum of the artery here. These are again microns in size. So this is the amount of precision which we can perform with the virtue of the robotic surgery. The patients usually are not concerned with what we are doing inside, but what they are more concerned is this. So this is the scar of a patient who has undergone a robotic radical prostatectomy vis-a-vis a person who has had an open prostatectomy. This person will go back home in 48 hours. This person will probably get out of the bed in 48 hours. The discharges are going to take at least a week or 10 days. This person will be fit to resume his duties within 7 to 10 days. This person will take at least 3 months of even home care to resume his duties. These are our numbers. So this is what the company does from time to time. So our results are assessed with the results worldwide. So what you can see here is that the amount of blood loss that we have had in approximately last 100 cases is less than 100 cc's. Our operated time are approximately just 2 hours plus. We have never had a conversion to open in a radical prostatectomy, and the return of urinary continence, which is the Achilles heel of this particular procedure, have been 92%. That's even better than the cohort studies which are available across the world. The second common surgeries that we perform are bladder tumor surgeries, that is removal of the bladder. And you can see this is the result after a robotic surgery. This person will take it around 5 days to go back. This person had had an open procedure. You can already see the wound infection happening here and here. So this person will probably stay in the hospital for at least a couple of weeks. This person will resume his duties within say around 2 to 3 weeks. He's going to take a while to recover. Kidney cancers have also been dramatically differently managed now. So initially, whenever we had a kidney cancer, it entailed removal of the entire kidney. But now, since we are able to see better, we are able to perform the surgeries better, renal preservation surgeries are becoming the benchmark. And the only single factor which has basically helped in renal preservation surgeries to become this famous is the robotic platform. And you can see for yourselves, so this is eventually the outcome of a partial nephrectomy which has been done by a robotic approach. And this is a partial nephrectomy which has been done by an open approach. You can already see there's a hernia there. So the outcomes were fabulous. We were able to save more kidneys more than before, in the era of the open surgery. We were able to help our patients oncologically, as well as we were able to manage their functionality also, along with quick recoveries. This is the surgery which I was describing. So 2019, our group was the first one which basically explained or demonstrated this kind of surgery to the world. CA penises are very common, specifically in steel workers, because of the hot and humid conditions they work in. So if somebody lands up with a carcinoma penis, we perform a groin dissection along with the management. So these were the times of open surgery. Just look at the amount of grotesque wounds. These patients used to be in terrible pain. Repeated infections required multiple procedures to cover these flaps. And these are the results of the robotic procedure. This patient is 10th day post-op. This patient is also 10th day post-op. The only difference is that this has been done by a robotic approach. This has been done by an open approach. Again, as surgeons, we always want to see the cancer and how fabulous it's going to be if we are able to identify. We have a technique which can actually show that, yes, this is cancer versus this is not cancer. So we have certain techniques called Firefly. So this is a dye which we inject into the tumor-bearing tissue. And the robot has an integrated system called near infrared imaging. So once you switch on that, the nodes which are first affected, or which are called the sentinel nodes, they basically glow. So this is how they look, and you just identify that, and rather than doing a complete surgery, you just take this particular node out, and in majority of the cases, almost 95 to 98% of the cases, you can avoid performing a complete dissection by just taking this node out, which is glowing like a bulb in front of your own eyes. So have we received or have we achieved what we wanted to do? No, we are still striving for better instruments. We are still striving to improve our results much beyond what we have now. So now the era has moved on. So you have seen multiple holes. Now people have moved on to single port laparoscopic and robotic procedures. Now we have flexible instruments which are much smaller than the ones which we already had. So 8 millimeters are now being replaced by 6 millimeter instruments. Multiple cuts are replaced by single cut. And what is now promising to be a very major path breaker in the management of cancers is telesurgery. So a surgeon can be seated in say Durgapur, and the case might be there in Calcutta, and the surgeon does not physically need to be there. You can actually perform the surgery sitting at whatever place you want to be, and this is now proven to be feasible even transcontinental, transatlantic. So sky is the limit, and I strongly believe robotics has actually made a major difference in the outcomes of how the cancers were being managed. And there is no looking back. I'm very sure in near future, we are going to have automated integrations. We are going to have integrations of virtual reality, we are augmented reality, and we would have much better results in the management of urological cancers. Thank you so much. And if there are any questions, I'll be happy to address.
Thank you, Dr. Tarun. It was wonderful presentation and a remarkable journey. And we were just saying that hence, in the next decade, we'll really move on to maybe complete robotics. If anybody is interested in.
Hello. Yeah.
Good
Excellent presentation.
Thank
I
you so
think
much,
really nice to take us through how it is. So if someone goes for the conventional surgery,
what would be the cost implication and what is it for robotic surgery? Because
Right.
that's a very important factor now
Exactly.
in the
So-
absence of insurance in all
Correct,
the
sir.
patients.
So as it stands as of today, the difference between a robotic surgery versus an open surgery is around 1.2 to 1.3 lakhs. Why this is happening is because of the disposables that we use in the robotic system, the company takes that share off. So every surgery, we use at least 3 to 4 instruments, and each instrument is a cost of around 20,000 rupees. So that's what the factor of 1 lakh, 1.2 lakh comes into the picture. But this is the commonest question which I get. The answer to look at it at a different perspective is that we are all employed, we are all in jobs. Unless we work, we cannot cater to our families. Now with a robotic surgery with a difference of a lakh, you are probably able to join your work within a week, versus if you have an open procedure, you're going to stay back at least 4 to 6 weeks in the rehab or at home resting, recovering out of that trauma which we have inflicted. So that probably counters the amount of money which we are spending. The second thing, with the advent of the Indian robots, now very gladly we are saying, and very proudly we are saying that we have now Indian robots also available, which have dramatically brought down the costs. So now in Da Vinci, the difference is 1.25. In the Mantra, which is the Indian robot, the difference is 40,000 rupees. There are a couple of other 5 or 6 robots from China, from Japan. So Da Vinci, the company, the one which we are using, had a patent for 20 years. So nobody could actually break that monopoly, so they were charging whatever they wanted. But now if you ask us, within next year what I foresee, the difference is not going to be more than 50, because now the company is compelled to compete and bring down the prices. So that's how the market should be. It should not be a monopoly driven market. So now the rates are coming down.
That's a very good hope.
So could you just, I wanted to know about this Indian, do you have any idea, or if anyone of your colleagues, so how good is it?
It's reasonable. So for, I would say for standard surgeries, like if you're doing a hernia, gallbladder, hysterectomies, it's wonderful. If you go for slightly more complex surgeries that we deal with, it is okay. But imagine a system which is there for 25 years and it has been improving over 25 years. Mintra has been there for last 3 years. And they have done a ton of R&D and they are improving their system every day. If they have 5 years, they would probably be excelling much better what the Da Vinci has done. So we should be very optimistic, and I'm very optimistic that it's going to change.
So Da Vinci, when you purchase that, it comes with a package of hand-holding, training. Does that happen with the
Yes.
Indian one?
Excellent question, ma'am. So yes. So what Indians have done, or what even Chinese have done, they have basically Xeroxed the entire ecosystem of any robot which was available. So the entire training program, so once a hospital purchases that, 20 trainings will happen over the next 2 years. 20 training means 20 surgeons can actually go at different time points to get trained. So that's a hand-holding which happens. So, and the second hand-holding is a peer-to-peer proctoring. So like Tuesday I'll be going to Patna. Patna has just installed, AIIMS Patna has just installed their robot there. So I'll be doing the hand-holding there. So I will be teaching them a couple of cases, being physically present there to handhold and to salvage any problems which happen. This will happen for till the time, say around 20 cases the surgeon performs and he's comfortable. That ends my training. So that's how the training happens.
So the Indian
same
package.
Same package.
Okay.
So
So my team from Jamshedpur will connect with
Surely,
you, and we
surely.
want to take this forward this
Sure,
year.
sure.
So,
Thank you so much. Thank you so much, and
Thank you.
have a wonderful evening. Thank you.
Now I will request chairpersons to felicitate our speaker. I'd also like to invite Dr. Binita Dwivedi ma'am to felicitate our chairpersons. So thank you, all the dignitaries, all the delegates, and all the speakers. And now we conclude the academic activity of today.
খোঁজো নিচে আছে তো উল্টো পাল্টার চার্জার না সব ওখানেই আছে চার্জার সরু পিনগুলো কালো আর মোটা পিনগুলো সাদা ল্যাপটপে আর আছে নিচে, ওখানে দেখো হয়ে যাবে, থাকবে এখানেই থাকবে, আর কোথায় যাবে? কনসোলের নিচে যেগুলো খোলা আছে নিয়ে নাও। এই নাজিবুল্লাহ, কনসোলের নিচে খোলা চার্জারগুলো ওকে দিয়ে দাও তো, খোঁজো কোনটা খোলা আছে, যেগুলো খোলা চেঞ্জ করা হয়েছে। চলে যাও, কালকে টাইমে চলে এসো। না, বন্ধ করে দাও।
Hello, check. Hello. Hello. Hello, check. Hello. Hello. Hello, check. Hello. Hello. Test 6. Hello. Hello, check. Check 1. Test 6. Hello, check. Hello. Hello. Check 6. Hello. Hello. Check. Check 1. Check 6. Hey, check. Hello. कोई ओवर नहीं. Hello. Hello. Check. Check 6. Hey, check. Hello. Check.
না আর কিছু করতে হবে না, হয়ে গেছে।